Across Texas, we are seeing longer, hotter summers, rising nighttime temperatures, and increasing health risk, especially among our most vulnerable populations. These include older adults, the unhoused, children, outdoor workers, and communities that already face structural inequities. Today is about bringing together diverse voices and expertise to better understand these risks and most importantly, to identify actionable items and solutions. I would like to begin first by extending our sincere appreciation to all of our sponsors and partners, Ascension Seton, the Alliance of Nurses for Healthy Environments, Concertra, the Cynthia and Michelle, I'm sorry, the Cynthia and George Mitchell Foundation, HAQ, Heat and Air Quality. Our outreach sponsors include the Association of Occupational and Environmental Clinics, Environmental Defense Fund, Environment Texas, Texas Public Health Coalition, the Medical Society Consortium of Climate and Health, National Physicians for Social Responsibility, and Public Citizen. Your support has made this summit possible and reflects a shared investment in protecting the health of all of our communities. As we move through the day, I want to emphasize that this is a flexible virtual space. We understand that many of you are balancing multiple roles. Please feel free to join sessions as you are able throughout the day. All sessions will be recorded and made available to you, so you will have the opportunity to revisit the content whenever you need. We have an outstanding lineup of speakers who will explore the impacts of extreme heat from multiple angles: patient care, public health, infrastructures, environmental justice, urban planning, and community resilience. These conversations are designed not only to inform, but also to inspire action across sectors. I would like to encourage everyone to join us for our final session of the day. This will be an interactive breakout session focused on what providers can do and what communities can do to mitigate the impacts of extreme heat. This session is an opportunity to move from discussion to action, to share any strategies, build connections, and identify practical steps that can be implemented in your own settings in your communities. At Texas Physicians for Social Responsibility, we believe that health professionals have a critical role to play, not only in treating health-related illness, but in advancing and advocating for policies and practices that prevent harm before it occurs. So today's summit is part of that broader effort to equip, connect, and mobilize all of us towards making a healthier, more resilient community. So again, I want to thank you for being here, for the work that you do every day, and for the commitment to advancing health in the face of a changing climate. So with that said, I will turn it over to our first panel for the day. Let me introduce Dr. McCarthy. Rhonda McCarthy is Concentra's Senior Director of Medical Surveillance and Telebehavioral Health Services, regulatory testing and exam medical expert panel. She's also chair and senior course director for Concerta's sponsored NIOASH, which is National Institutes of Occupational Safety and Health, for their spirometry training program. She is a graduate of the University of Texas Medical School, Houston MD Medical College of Wisconsin for her MPH, and the University of Pennsylvania Perelman School of Medicine for Occupational Medicine. She is board certified in Occupational Environmental Health Medicine and a fellow of the American College of Occupational and Environmental Medicine and the American College of Preventive Medicine. So with that said, I'll turn it over to Dr. McCarthy. Good morning, Dr. McCarthy.
Thank you, Dr. Cantu. So I will begin with a high-level overview of heat exposure and how heat can impact health. Next slide. Heat exposure represents one of the most rapidly intensifying environmental health threats in the United States today, and Texas has emerged as one of the most impacted regions due to its geographic location, urbanization, and climate trajectory. The increasing frequency, duration, and intensity of heat waves has resulted in a growing burden on our healthcare systems with more emergency department visits, hospitalizations, and preventable deaths tied directly to excessive heat exposure. Rising ambient temperatures combined with high humidity levels that inhibit evaporative cooling drive the physiologic strain that leads to heat-related illnesses in individuals. Clinicians are seeing a broader spectrum of presentations ranging from heat rash to heat exhaustion to heat stroke that can result in neurologic impairment, multi-organ failure, or death without rapid intervention. Heat exposure also exacerbates chronic illnesses such as cardiovascular disease, asthma, and renal impairment. Texas clinicians, well, all clinicians, must be prepared for this growing burden, especially as nighttime temperatures rise and reduce opportunities for physiologic recovery. This state's unique occupational and demographic composition include large numbers of outdoor workers, households with limited access to cooling, and communities experiencing disproportionate climate impacts. This amplifies the urgency and the understanding heat's direct and indirect health consequences. As our ambient temperatures continue to increase, clinical awareness and preventive counseling will play an increasing essential role in reducing serious illness and death from heat exposure. Next slide. There are three elements that increase our risk for heat strain. We have external heat load, internal heat load, and personal risk factors. It's these elements that are balanced by our compensatory mechanisms, which include thermoregulatory and behavioral. The external or environmental heat load, we're not yet, we still stay on that slide. Thank you. The external and environmental heat load is determined by more than just air temperature. It reflects a combination of atmospheric factors that interact to increase the heat load on the human body. We have humidity that plays the central role. When moisture saturates the air, our sweat evaporates less efficiently, impairing the body's primary cooling mechanism. Radiant heat from the sun or surrounding hot surfaces adds additional thermal stress, particularly where there's dark surfaces absorb and then re-emit heat well into the night in urban areas. This is termed the urban heat island effect and can add an additional 10 degrees to air temperatures in urban areas. Wind and airspeed also determine the net environmental heat burden on populations. So when air temperatures or wind temperatures are greater than body temperatures, that can actually add to our heat load. It's these environmental conditions that they do not impact all populations equally. Vulnerable groups such as low-income households, they may live in older housing structures without adequate insulation or air conditioning. In our clinical settings, understanding these environmental drivers of heat exposure helps clinicians connect these physiologic complaints to environmental realities, particularly during heat advisories. Understanding environmental contributors to heat stress is crucial for appropriately recognizing risks, counseling our patients on preventive measures, and anticipating surges in heat-related illnesses during extreme weather events. Next slide, please. Internal or metabolic heat load is when our body generates heat by cellular metabolism. This will increase as our body increases with muscular activity. So our physical activity will increase our internal heat load. Under normal conditions, our body regulates our core temperature near 98.6 degrees Fahrenheit through our thermoregulatory mechanisms, such as sweating and peripheral vasodilation, shunting the blood to our extremities and skin to dissipate heat, and behavioral mechanisms such as drinking liquids, seeking cooling, shedding clothing, and rest. So decreasing the activity to cool our bodies. When external and internal heat loads exceed the body's adaptive capacity, for example, when humidity prevents that evaporative sweat or behavioral mechanisms are restrained, heat accumulates rapidly. Early physiological signs include increased heart rate, rising core temperatures, and mild dehydration. As heat strain intensifies, the cardiovascular system struggles to maintain that perfusion while simultaneously supporting thermoregulation. So this leads to low blood pressure, decreased kidney perfusion, and a potential to progress to acute kidney injury. You also can have electrolyte imbalance that will trigger muscle cramps. And then central nervous system dysfunction can emerge when those core temperatures exceed critical thresholds. Next slide. Heat-related illness encompass a broad spectrum of clinical conditions that arise when that heat accumulation exceeds the body's ability to dissipate it and you meet those critical thresholds. At the mild end of this spectrum, there's heat rash, which is caused by blocked sweat ducts, and then heat cramps when you have that electrolyte depletion during prolonged exertion in hot conditions without replacement, like a sports drink. Heat syncope occurs when that peripheral vasodilation, the shunting of the blood to the extremities to dissipate heat, will lead to that sudden drop in blood pressure, causing fainting episodes, which then can lead to accidents, or which we call heat-related accidents. Heat exhaustion manifests when symptoms such as dizziness, nausea, increased heart rate, headache, profuse sweating. It reflects significant dehydration and cardiovascular strain, and this often precedes more serious illness when left untreated. The most severe condition, heat stroke, is defined by a core temperature of about 104 degrees or 40 degrees Celsius. And another key feature is central nervous dysfunction. So the difference between heat stroke and heat exhaustion is that central nervous dysfunction, because the thermoregulatory system is now disrupted. And so you have confusion, irrational behavior, and then more severely, seizures, coma. Heat stroke represents a true medical emergency. You want to address it just like you would a sudden cardiac arrest. Minutes matter. It requires immediate cooling to prevent multi-organ failure and death. So every minute matters. You want to know to immediately cool in the field before transfer to an emergency department or wherever you address knowledge of a heat stroke. It is essential for clinicians to recognize this spectrum, to intervene early, and to understand the broader spectrum of heat impacts. Next slide. Extreme heat, has, we just said, has a wide range of systemic effects that extend far beyond the classic heat illness that we just discussed, influencing not only the heat illness spectrum, but also cardiovascular, respiratory, renal, neurologic, and mental health outcomes. So persons with chronic illnesses and taking certain medications, this cardiovascular strain increases the cardiovascular strain as the heart works harder to maintain blood flow for this thermoregulation can lead to exacerbations in heart failure, arrhythmias, and ischemic events. There are well-established research studies that consistently show there are increased cardiovascular mortality during heat waves. Respiratory health is also impacted. Heat contributes to worsening air quality through formation of ground-level ozone and particulate matter, and this will exacerbate persons with asthma and COPD. Renal systems are particularly vulnerable because that dehydration and decreased renal perfusion and glomerular filtration will increase the risk of acute injury. So persons who have recurrent heat stress, recurrent dehydration, and with physical activity, particularly labor-intensive occupations, have been associated with the emergence of chronic kidney disease in the absence of traditional risk factors. So you have young men and women, but particularly men, in very labor-intensive occupations that have this repeated dehydration, heat-related exposures that have these acute injuries over and over, that then are having chronic kidney disease diagnosis at a very young age. Heat also affects mental health. It's contributed to violent behavior, impaired cognition, sleep disruption, and then increased rates of heat-associated psychiatric emergencies, including suicide. These systemic impacts illustrate that heat exposure should be viewed as a multi-systemic clinical threat rather than a narrow occupational hazard. Next slide. So it's important to have early recognition of these heat-related illnesses and it's essential for preventing progression to life-threatening conditions. You want to have a high clinical suspicion during heat advisories or when patients are engaging in prolonged outdoor activities. Think outdoor workers, athletes, whether in school or professional, and even the spectators. Patients may report dizziness, headache, nausea during the early stages, and these are pretty nondescript symptoms, but they should prompt immediate assessment during periods of high heat environment, especially when it coinciding with increased physical activity. Red flags for impending heat stroke would include those neurologic or altered mental status, confusion, irrational behavior. You think someone's acting crazy. They may look like they're drunk, walking, incoordinated walking, ataxia, and seizures. Individuals with chronic health conditions may exhibit exacerbation of these conditions triggered by heat exposure, even in the absence of classic heat-related symptoms. Incorporating the environmental history into your medical record and into your history taking by inquiring about time spent outdoors, access to cooling, or high intensity physical exertion can improve diagnostic accuracy. Also, clinical documentation in your medical record and accurate ICD-10 heat codes, such as T67 codes, the X30 codes, are essential for epidemiologic tracking of these underreported and underdocumented illnesses if we are to improve our understanding of the true scope of heat-related health impacts. Next slide. But even more important is preventing these heat illnesses from occurring in the first place. Heat-related illnesses and death have been stated by OSHA and many other entities that they are entirely preventable. Core prevention principles include ensuring adequate hydration, access to cooling and shade, and structured rest periods during hot weather. In addition to these core prevention principles or acclimatization, this is one of the most effective physiologic protections. It allows the body to gradually adapt to heat through improved sweating efficiency and cardiovascular stability. It is most feasible to apply this in workers and athletes. Control measures such as adjusting activity schedules to cooler times of the day earlier in the day and improving airflow through ventilation or fans further supports cooling. But again, these ventilation and fans are effective if when the temperatures are under body temperature. Public health recommendations are important to emphasize early recognition, community alerts, ensuring access to air-conditioned spaces during high heat periods. Texas presents unique challenges due to policy environments that may limit workplace protections. And so clinicians and other advocacy policies need to be in place for patient education. Clinicians are an important advocate for patient education. These preventive strategies lay the groundwork for transitioning into a deeper discussion of our population vulnerabilities, which is critical for targeted risk reduction for the personal risk factors that we will go into. So the other aspect of what adds to our heat burden. So I'd like you to remember all these things as we go into the vulnerable risk populations. Next slide, please. So that third element of an individual's ability to balance heat load are personal risk factors. So we touched briefly on chronic illnesses, and so now we'll look more at specific populations. For example, children. Children have an immature thermoregulation and depend on adults for hydration and climate control, thereby increasing their heat risk. In pregnancy, you have increased pregnant women have increased cardiovascular demands. Heat exposure is linked to preterm birth and low birth weight. Older adults have less sweating and thirst response, and more often have chronic diseases that we discuss, which heightens heat vulnerability. So it looks like now we should move on to our next speaker to go into some of these vulnerable populations. But before we jump into our next two speakers, I want you to note that you can use our chat to enter your questions, and then we will save time at the end for Q&A, whether we take questions from the chat or you ask verbally. And we will have 20 minutes for Dr. Carter and 20 minutes for Dr. Salapas, and then another 20 minutes for our chat. So I will go ahead and do the introductions for both of our speakers, and then we'll move on. Thank you for your time for the introduction. And without further ado, Dr. Kimberly Carter is a board certified obstetrician gynecologist at Seton Women's Health, which is a clinical partnership between Ascension Seton and UT Health Austin. She is assistant professor at Dell Medical School Department of Women's Health.
I'm an associate professor, by the way.
Oh, I'm sorry. Thank you. She is associate professor at Dell Medical School Department of Women's Health. Dr. Carter completed her medical and residency training at Baylor College of Medicine and holds a master's degree in public policy studies from the University of Chicago. She is an active member on several professional committees and currently serves as co-chair of the Texas Medical Association Select Committee on Medicaid, CHIP, and the uninsured, and the co-chair of the task force on the healthcare coverage, among many others. Dr. Irvin Salapas is an associate professor in the Department of Family and Community Medicine at UT Health Houston. He is a primary care sports medicine physician and serves as a team physician for the Houston Dynamo FC, University of Houston, University of St. Thomas, and Texas Southern University. Dr. Salapas also serves as one of the medical captains for the Chevron Houston Marathon. He brings many years of experience covering games and other athletic events, which includes taking care of athletes in hot climate conditions. So, Dr. Carter, thank you.
All right, and thank you so much. I apologize for being a little late. I actually thought this was tomorrow, and we're doing academic things today. So not quite camera ready, but very enthusiastic about this. So thank you for joining us today to discuss what is the biggest threat to public health. So as an OB-GYN, I'm going to focus on the effects of reproductive process, of how heat affects the reproductive process from preconception to birth. So next slide. Basically, climate change related heat exposure has significant adverse effects on human reproduction, including fertility, pregnancy outcomes, and birth outcomes that have, in turn, have long-term consequences to the newborn as they grow into adulthood. So these slides are geared towards the medical community, but I'm going to hit the highlights, but I wanted to leave some details in case people wanted those kind of details. Next slide. So one of the things I wanted to focus on is how does our body deal with heat stress? We deal with it by using something called heat shock proteins to help our bodies regulate our exposure to heat. So the body has an ideal temperature at which it functions. And one of the really cool things is that because of sanitation, better dental hygiene, the fact that we can wash off a cut after it occurs and we can take anti-inflammatories, is that our regular body temperature is no longer is 98.6. It's actually more like 97.8. And this is because of modernization. And so our metabolic rate has decreased through advances in modernization, which actually gives us a little bit more leeway to deal with heat. Next slide. So what happens is we get exposed to heat by being outside, working outside. It's being a part of a heat wave, and our heat shock proteins go into effect to help us to regulate our heat. So it causes our blood vessels to dilate so that we dissipate heat and we sweat, and it protects us on the cellular level so that our kidneys continue to function and that they help us to conserve water. Now, it's not that you necessarily run out of heat shock proteins, but you can overwhelm the system if you keep hitting it with heat. And then at that point, once you overwhelm the system, that's when you can start to get heat-related illnesses. Next slide. So in every single study, they use this term prolonged exposure without always defining it. So I wanted to make sure that everyone knew what prolonged exposure is, because prolonged exposure is what defines whether or not your body is overwhelmed by the heat shock protein protective effects. So it can be being outside for 2 hours, like going to see a parade or just being at the park. It could be because you're working outside all day. It could be because you're outside during a heat wave and you're waiting outside for 30 to 45 minutes, just waiting at a restaurant. You can still overwhelm it. It also depends on who you are. So we know that some populations are more vulnerable to heat stress, such as our elderly and are very young and are pregnant. So next slide. This is a really busy slide, but it shows how heat stress starts and acts on our brain. So it starts by affecting the hypothalamus, which sends the signals to our sex organs, and therefore it's going to affect our reproductive process. So I'm going to start with the male reproductive system. Next slide. So why is the scrotum external? Well, it's because it needs to live about 5 degrees Fahrenheit at a temperature less than the rest of the body. So it needs to be around 92 to 93 degrees in order to make the steroids that it needs to do to make sperm. And if it doesn't, if it gets heated, then it's going to inhibit the ability to make testosterone. And it in turn will downregulate your sperm production, and it will affect the motility and the morphology of the sperm. So next slide. So what that means is that heat will affect your ability to have a normal sperm count. It'll make your sperm move in funny directions. So instead of moving forward, they'll swim in circles. It'll make sperm have two heads or two tails, which also is not going to be infected. And then the worst insult is that it will cause degradation of the DNA. So every sperm has half of the DNA of its donor. And if it doesn't have a complete helix, then when it goes to meet with the egg, then it's not going to be able to successfully make an embryo because of the degradation of the DNA. So next slide. So we know for sure that when there are heat waves, that it affects male fertility to the extent that we see 9 months later a decrease in birth rates. And it's a decrease that can't be explained by things other than the heat wave. And that is because once you affect the sperm, you are unable to unaffect the sperm. You are only able to make new sperm. So it can take up to 30 ejaculations before you can get sperm that are unaffected by a heat assault. And again, how long does it take? Well, it may take as little as just 30 to 45 minutes, depending on the situations. Next slide. So this is really serious because the sperm count in the world has decreased, but in particular in industrialized nations like the United States. And these statistics are specific to the United States, but we've had a 59% decrease in the total sperm count. If we continue on this trajectory, then we will have zero sperm by 2045. Next slide. And I know that people are out there saying, well, the birth rate is declining, and it's because women have access to birth control and education. And this is true. When women have access to birth control and education, we do choose not to have 11 children, and we do limit the number of children that we have. But it doesn't explain the fact that we're having to use much more assisted reproductive technology in order to conceive. And our sperm count has begun, the decline in the sperm count has begun to accelerate over the last 2 decades. So that instead of losing a total amount of about 1.6 per year, we're now losing at a rate of 2.6 per year. And the sperm count is affected by other things other than just heat. It also is affected by endocrine disrupting chemicals and pollution, but that's another lecture. Next slide. So, in summary, it's affecting male fertility. It's doing this in a permanent way because, again, once the sperm has been heated up, that's a permanent effect until you get new sperm, and it really needs our attention. So, now I'm going to transition over to female fertility. Next slide. So, just as you saw on that very busy slide, it affects our pituitary axis, which means that the hormone signals to ovulate, the hormone signals for how long the follicular phase and the luteal phases of the menstrual cycle should act, get affected by heat because the heat stress tells you, ooh, this may not be a good time necessarily to ovulate. It's also going to affect your production of your steroids. So testosterone is found in women because it's a precursor to estrogen. So if you're affecting the testosterone in men, you're also going to affect the testosterone in women, which is then going to affect our estrogen production. Next slide. So the stages of vulnerability are throughout the entire cycle. Every woman is born with all the eggs that she's ever going to have. And when I was pregnant with my daughter, I was actually also pregnant with the genetic material of my future children, of my future grandchildren, right? Because she was also born with all the eggs she's ever going to have. And what happens is that your eggs are really quiet until you go through menarche, so when you become puberty, and then you begin to ovulate. Well, if you're exposed to a lot of heat, then those little eggs that for that cycle decide to race to become the number one egg that throws out the number one antral follicle, I should say, that throws out the egg for ovulation, um, you will affect that by heat so that things that can happen are that there's a lot of heat and then the body gets the wrong signal and it throws out the egg prematurely, so it is unable to be fertilized because it has not gone through all the stages of maturation. Or it doesn't get thrown out at all, so you don't ovulate. It also disrupts the genetic material in that particular egg. And as the final insult, even if an egg and sperm make it all the way through the process to fertilization, it can affect the endometrial lining so that you don't have successful implantation of that embryo. Next slide. So the immediate effects of heat on the ovulation cycle are that it causes the decline in the hormones that tell you to ovulate and that allow for implantation. The long-lasting effects are that it may be that it affects multiple cycles. And so the heat event that affects that cycle may last longer because the antral follicles that were lining up for the next cycle may still be affected by the heat. Next slide. So we know for sure because of our data that we collect from doing in vitro fertilization and ovulation stimulation cycles in both humans and cows and horses that we are always have less fertile cycles, so we collect less eggs during the summer months. There is always a decline, and we have less ability for the follicular phase to support the egg and sperm once they are fertilized. And this seems to be a heat-related quality. Next slide. So in summary, basically, it reduces the ability of the ovulated egg to do its job in a normal way. So to allow the sperm to come in order to allow for the DNA to join, and it disrupts the ability of the egg to implant in the endometrium. Next slide. There's I know there's people here who are researchers, so I always like to point out research opportunities because there's a lot here. And we really do need to understand how long in a menstrual cycle, so or how many cycles might be affected by a reproductive female's exposure to prolonged heat. Next slide. Now I want to move over to heat exposure and pregnancy. So this heat exposure during the pregnant for a pregnant patient uniquely is dangerous to two people. So it's dangerous to the fetus and it's dangerous to the mother. Next slide. We have a danger season in the United States, and it is between May and October. For the last 10 years, heat have been the hottest summers on record, and heat is our number one weather-related killer. So to add insult to that, it also happens to be hurricane, flood, and wildfire season, and all of those things knock out one of our main ways of dealing with heat, which is to go inside into air-conditioned buildings because it knocks out our power supply. Another thing that really needs to be focused on is that pregnant women are not included in disaster planning. So we do not have specific evacuation plans and specific facilities that include pregnant women as a vulnerable population, and that's a place that we could improve upon. Next slide. So why are pregnant women more vulnerable than non-pregnant women? Well, remember, our body temperatures now are sitting at a lower temperature, around 97 degrees. But for a pregnant woman, the little phrase, you've got a bun in the oven, is actually really apt because when you are pregnant, your basal body temperature increases. And so you live at a higher temperature. And when you live at a higher temperature, your ability to deal with heat-related stress is going to be different. And there are so many physiologic changes that happen during pregnancy, like you lose 30% of your ability to breathe, your eyeball shape changes. There's so many things that people don't think of, but these things all affect our ability to deal with stress-related heat when we are pregnant. So our adaptation is changed. Next slide. So what does this mean for clinical significance? Well, if you're exposed to high heat for a prolonged amount of time, again, sometimes this can be as little as 30 to 45 minutes, it increases the risk of the baby dying, especially if you're exposed in the last 4 to 5 weeks of pregnancy. It causes growth restriction, and growth restriction can lead to lifetime consequences. It causes preterm delivery, and we know specifically that for every 1.5 degrees of Fahrenheit rise in temperature, there is a corresponding 5% increase in the rate of preterm birth and stillbirth. If you're exposed to prolonged heat in the first trimester, it increases the risk that you will have a heart defect if you're a fetus, that you might have spina bifida, and that you can develop cataracts. For pregnant women, you're much more prone to exhaustion, heat stroke, and kidney failure. Next slide. So the preterm birth and the IUFD rate is definitely dose related. So the more you are in a high heat situation and the hotter the heat, then the more likely these things are to occur. Next slide. So there are long-term consequences of being exposed to high heat situations for a prolonged amount of time in utero. So one is that the smaller for gestational age and the birth defects that we talked about, but it also can alter how tall you can be as an adult. It increases your risk of heart disease, mental health conditions, and high blood pressure. And our studies are definitely showing that male fetuses are more affected than female fetuses. Next slide. There are definitely gaps in policy as well as research on pregnant women and heat. So again, I want to encourage that we consider public policy ways of dealing with heat in pregnancy, such as recognizing that pregnant women need to be a part of disaster planning and be prioritized for cooling centers. There are opportunities for us to increase public awareness for how to recognize that you are in a high heat situation, how to treat yourself, and how to avoid those situations. And then we need to understand because there's no studies showing what are the best interventions we can do for the pregnant population to avoid heat-related illnesses. Next slide. So what can we do? Well, on a micro level, we can make sure that our patients know about heat advisory times, that they should not go outside and exercise or do outdoor activities. We can raise awareness on how to recognize and prevent heat related problems. The University of San Francisco has a whole program developed about and research about climate change. And they have made a lot of missives that you can use to give to your patients, for example, that can help them to recognize some of this stuff. At a macro level, we have to recognize that fossil fuels are directly contributing to the increase in heat over the last couple of years. And so that we need policies to become less reliant on fossil fuels. And then, as I've already stated, we need to include pregnant patients in disaster planning. Next slide. So these two headlines were within days of each other last month. And I thought it was really interesting. The first headline came out was that the US fertility rate dropped to another record low. So last year in 2025, we had 750,000 less babies born. And part of that was because we have improved the rate of teen pregnancies. But in some ways, that's a little bit of a false flag because the teenagers do grow up, they become 20 and 30-year-olds, and they still reproduce. And we have less immigrants having babies because we simply have less immigration. And if you look at the study that talked about the US fertility rate dropping, they also say, well, there's other factors too, but they don't really go into that. And then just a few days later, we came out with the headlines that March shatters US heat records. Well, we know that the two are related. So the increase in heat is for sure affecting our fertility. And the amount of heat, I think, sometimes surprises people. So if you're in Arizona, you may not, you have better adaptation to heat. And so prolonged heat exposure for you may not kick in until you're in the hundreds. But if you're on the East Coast, it may kick in if the temperature is in the 80s. So hopefully you've learned to put this all together, how heat definitely affects our reproductive process. This is a really critical illness and it's going to affect our future. These are and you can go to the next slides. These are just some of the resources that I used to make this lecture. Thank you.
Thank you, Kim. Dr. Carter, that was very, very insightful, very interesting. And we will move on. Please remember to put any questions you have for Dr. Carter, myself, or Dr. Salapis in the chat for after the discussion or during. And now we'll move on to Dr. Irvin Salapis.
All right. Hi, good morning, everyone. I'm Dr. Irvin Salapis, and pardon for the background noise. I'm actually at the Houston Dynamo training facility and outdoors in the heat currently right now. So, I wanted to talk about heat safety for the adolescent population, especially in the middle school and high school sports. High school football is going to be right around the corner. There's going to be a lot of sports going on during the summer when school's off. So I wanted to talk about that. Next slide. All right. So why does this matter? It does feel like Texas is getting hotter. That's a whole other conversation from another topic about how our heat index is just going up and up. However, heat illness is preventable. It's still leading a cause of death in sports, especially with teen athletes. Especially early in the season. I feel like August is once school is about to start. Everyone's doing their preschool days of practice is going to be the most dangerous time. Kids, teenagers, and student athletes, they are not as conditioned, before getting back to school, and that's that vulnerable time where you really need to monitor that. Early recognition saves lives. Now, who's at risk? We talked about teen athletes. They do high intensity workouts. They do increase heat exposure. People who work outdoors. the elderly population, even younger children, right? Younger children, they actually exude a lot more heat out, and also they're less able to communicate in distress, and they also overheat faster. And anyone with medical conditions, diabetes, high blood pressure, kidney issues, those people greater risk. Next slide. All right. So why are teens unique? They produce more heat than or body mass, especially once after they hit puberty. In terms of sweating, they sweat less efficiently. And we've all been teenagers at some point in our lives. We do push harder. As teens, they do push a little bit harder and ignore symptoms as well. And they might not even recognize any early signs that they may be overheated. So how does the body handle heat? You have kind of this heat balance where there is the heat in versus heat out. The heat in is produced by exercise or any type of physical activity. And then your body tries to exude that heat out using through sweat, going the blood flow to the skin. Dr. Carter mentioned about the body temperature. Typically, the body should stay between 97 and 99 degrees to function properly. Okay, next slide. All right, so risk factors for heat illness. So physical factors. You're high risk for our overweight teens or those who have deconditioned or in poor physical fitness shape. Have they recently been sick, like coming off from an illness, whatever it may be, how minor it may be, it's still relevant, may have increased risk of any heat illnesses. Have they had a history of prior heat illness before? And also a big thing is knowing if they have sickle cell disease or even trait. If they have a sickle cell trait, they're actually increased risk for dehydration. For the environmental factors, high heat and humidity, there's no shade in the practice. If the turf or the outside fields are a little bit darker, where like the astroturf feels darker, hotter than the air. And then the key for helping out is to do early season practice before acclimatizing. People take medications, ADHD stimulants, right? Like Adderall or Ritalin. Anyone taking antihistamines, anyone who's on antidepressants or antipsychotics. Big things are beta blockers that can slow down the heart rate, and also taking diuretics that can make you a little bit more dehydrated. Big thing to discuss is also pre-workouts. I know that's a big thing with the teenage population, and any type of dietary supplements that may put them at risk for dehydration. And also the last thing is behavioral, right? Not drinking enough water. Are they wearing full pads kind of practice? Are they wearing dark colored uniforms to where they're absorbing a lot more heat? Are they pushing through the warning signs? And then there's no acclimatization period. Next slide. So when do things go wrong? When your heat production is greater than your heat loss, right? When you're dehydrated, it's also kind of limiting your cooling. I always tell every person that if you're thirsty, you are already behind. So you got to adequately hydrate. Even when you're not thirsty, just kind of drink water when you're doing your physical activity, so you're not feeling dehydrated later on during that physical activity. Hot and humid conditions overwhelm the body, and then also when the core temperature rises too high. Next slide. So early warning signs. I know Dr. McCarthy has already talked about this, but I'm just going to briefly go over it. So with mild heat illness, you'll have some muscle cramps, you feel tiredness, headache, dizziness, and also you're sweating a little bit more. So once you see this, stop, take a little break, cool down, get yourself hydrated. All right, next slide. All right, so the next level up from that is heat exhaustion. A little bit more serious, but it can be treated. So this one's your sweating's a little bit heavier. You're getting a little bit more headache. Sometimes you feel nauseous. You're muscle cramping. You're also tired. Your skin feels a little bit clammy. and sometimes your skin actually feels cool. You check your pulse, you're fast, a little bit weak. This is technically not a heat stroke, but it's still pretty serious. This is the one where you actually have to move into a cool place, get that athlete into out of the heat and into the shade or some air conditioning, tell them to sip cool water or have a sports drink. This is the one where you don't give any caffeine. Cool the body, wet towels, ice packs on the neck or armpits or groin. And that's where kind of like the big uh, blood vessels are to help kind of cool the body quicker, or use a fan or air to help it move. This is the one where you kind of monitor the the athlete, kind of stay with them. Symptoms should improve over 30 to 60 minutes. If not better, they need to probably have some higher level of care. All right, next slide. All right, so the other thing is heat syncope. This is basically when someone passes out due to heat. They'll usually say that they're feeling lightheaded or dizzy. Sometimes they'll feel nauseous. They'll also have that pale or clammy skin. Sometimes their vision kind of tunnels a little bit, and things are like maybe things are blacking out from the sides. They feel weak, and then they finally pass out. Who's at risk? Athletes, and I've also seen this in band, right? Don't forget, high school band is also outside in the heat during this practice. And these are the individuals who stand for long periods of time doing just standing with their instrument. That's the kind of, if they're not adequately hydrated, they'll feel lightheaded and then pass out. Um, People who aren't used to the heat just yet and trying to acclimatize to it, there's risk. And then those with history of blood pressure, low blood pressure. With these, if they faint, bring to a cool shaded area, lay that person down, elevate their legs. Once they're alert and they're talking a little bit and they feel like they'll be able to swallow, give them a little sips of water and a cold drink. And then just kind of monitor them and then try to seek any medical attention if needed. All right. Next slide. All right. So the last thing is a heat stroke. This is a medical emergency. These are the ones that you don't want to hear in the news, but when you do hear in the news, it's really, really unfortunate. This is where their core temperature, which is the rectal temp, is over 103 or 104 degrees and up. This is where they're confused. It looks like they're either talking through you but not at you. They may have like low level of consciousness. They're actually not sweating at this point. The skin is hot and dry, and then they collapse. This is the one where you actually call 911 immediately. The gold standard is to put them in an ice bath. I'm actually outside of the facilities here. The team practices in about an hour. Behind me are actual cold tubs. Here's a shower here. And then over behind those cold tubs is actually an ice machine. So we do have protocols in place, even with the professional athletes, to monitor for any heat. The goal is to monitor that rectal temp to make sure it goes down after within 30 minutes. Remove everything, remove the pads, the helmet, any excess clothing. This is one where you do not give fluids by mouth if they're confused or any unconscious. Cool first, transport second. All right. So fast recognition for a heat stroke is vital to actually save a life. All right, next slide. So something I want to talk about, especially in the sports aspect, is we look at the wet bulb globe temperature. This is the gold standard to measure how hot it is for sports. It's a combination of the air temperature, the humidity, the wind speed, and then the sun's direct heat. This is used by the U.S. military. A lot of sporting events. For those in Texas who participate in sports, UIL actually uses this as a standard, and most state athletic associations. It is the official outdoor activity heat standard since 2023. All right, next slide. So these are the actual guidelines from the Texas University Interscholastic League. So when the zone is green, that is the wet bulb globe temperature. When it's like less than 80, this is for, now mind you, this is for practice. Okay, so it's a little bit different for games, but for practice, whether if it's like football, soccer, field hockey, lacrosse, anything outdoor, we always check the wet bulb globe temperature. At least the athletic trainers do. So if it's green, you can have normal practice, provide water access at all times. When the temperature hits around like the low 80s, that's where moderate risk is. Increased rest breaks. Watch for early signs of any heat illnesses. Make sure that you have an area that you do have a rapid cool zone required. When it's orange, that's around 82.3 to around 87 degrees. That's high risk. This is where you reduce intensity, have a minimum of 3 to 5 minute water rest breaks per hour. So make sure that they have like a 5 minute water break every 15 minutes. And then you do no full pads. So when it's around like 85 degrees, you should just be practicing with no pads. Um, and then have water breaks every 15 minutes that last for about 5 minutes. Now, when the temperature is red, around 87 to 90 degrees, you limit the practice to 2 hours max. You only do walkthroughs, helmets and shorts only, frequent breaks. And then if it's a black, which is over 92 degrees, you suspend all outdoor activities, no exceptions. And this is a hard rule. This is why I know as parents, it's very hard to like drop off your kid at 6 o'clock in the morning for practice during the summer, or 7 o'clock in the morning practice in preseason. But this is the very reason why high school practice before school starts is usually around 6, 7 o'clock in the morning, or they do late practices like around 6 or 7 p.m. Yeah, and they do limit depending on the temperature, depending on the sport too. They'll kind of limit what's to be done during practice. Now for games, they always check that wet bulb globe temperature. And then last season, there's been a big trend in delaying some high school football games till 8 p.m. because it was still hot at 7 o'clock. So that's all based on the wet bulb globe temperature. All right, next slide. So what do the schools do right now? So they monitor the wet bulb every 30 minutes. The first reading has to be done 15 minutes before practice starts. Cold water immersion is required. Every school must have ice tubs or a taco tarp. Taco stands for tarp assisted cooling oscillator. It's basically a big tarp, and then you just roll the person up in a taco, dump some ice in there, and just kind of oscillate them. We use those at the Houston Marathon. Unlimited water access. Coaches must never deny an athlete water, and rest breaks must include hydration with no physical activity. And then every school does and should and does have an emergency action plan that's written for any heat illnesses. Coaches and staff must be trained and prepared. They do those. They review those on a yearly basis. Next slide. UIL requires to have that written heat emergency, designated responsibilities, clear roles for the coaches, students, athletic training staff under the heat emergency contacts, cold water protocol, where EMS or knowing how to access EMS is good, and then how to communicate. And also, anytime that there's an incident, you always do a post-incident review. All right. Now, the big thing is how to acclimate. So typically you acclimate over about 10 to 14 days to get used to the heat. So at the very beginning, the first 2 days, you can maybe practice with light intensity up for about an hour. And then over like the middle of the week, you go up to 2 hours. And then starting next week, you can go high. So usually it takes about almost 2 weeks to get acclimated to the heat. And this is why before football season starts, the high school kids usually start practice a little bit light, starting at the very beginning of August, and then they should be acclimated by the end of August. It takes, if an athlete is sick, they need to take 3 days off and to restart the acclimatization process. Okay, next slide. So hydration is important, as we all know. Drink 16 to 24 ounces of water for every 2 to 3 hours before activity. And then for every 15 minutes, try to drink, 15 minutes before activity, try to drink about 8 to 12 ounces of water. Now, during practice, they should drink every 10 to 20 minutes during the activity. If they're ever thirsty, they're already behind, so they need to rehydrate and keep drinking. Thirst is do not wait until you feel thirsty. In terms of urine, their urine should be pale yellow at the latest. If it gets darker than that, that means they're not hydrated well enough. And make hydration a habit for everyone who participates in sports. All right, next slide. Clothing, wear lightweight, breathable fabrics, choose light colors. Don't forget any accessories like a hat, visor, sunglasses, and keep things simple, avoid any extra layers and heavy gear. We talked about timing, and this is why practice is done like either early morning or very late at night. Give athletes about 1 to 2 weeks, probably towards later in the 2 week, to adjust to the heat and kind of monitor them, and also stay hydrated and seek shade if needed. Next slide. All right. So for parents and spectators at the games, always check the weather and heat index before you go. If it's really hot, consider a different time. Stay hydrated, dress smart, seek shade, and also know the signs of any heat illness too. So heat impacts more than safety, it impacts performance. So with exercise, they have increased heart rate. They tire out faster. Sometimes they reduce focus. Their increased risk of injury if they're not acclimated to the heat, and overall decreased performance. So this is why acclimatization is important to the heat, and also trying to get more physically active, better fit for the sport that you're participating in. Right. Next slide. And this is just a kind of a summary of, recognize the signs for heat stroke, cool them down immediately, and then call 911, and then respond appropriately. All right, next slide. Everyone has a role in this, not just the athletic trainers and the coaches and the athletic trainers, but also parents and families as well, especially if you're watching out practice or going out to the games. All right, next slide. All right, and that's all I have. Thank you.
Thank you, Dr. Salopis. That was both these lectures were very informative, very just essential for us as Texas and other states that deal with heat exposure. It is very wide ranging. It's not only Texas, although we are significantly impacted. And for those of you that are interested in occupational heat exposure, these athletic recommendations really align to many of the recommendations from OSHA and NIOSH. So you can use those recommendations as well. So they are very much in line. I mean, there's obviously differences. There are questions that we can take from the chat, or if somebody wishes to just ask verbally, if they, I'm going to see if I can figure out how to take the questions from the audience here as well, if you raise your hand, and we can open up the questions, but I'll read them out. There were from Aaron Marcus, are there any wet bulb calculators that you prefer are there any wet bulb calculators that you prefer, and how much do they cost? Or should we use the National Weather Service information? And I'm not sure if this was meant for referencing athletics.
If it's just in the outdoor environment, like work or something like that, you can technically use the calculator online. However, you have to know about what you're practicing on. So, like specifically for sports, like if you're on turf, like AstroTurf, that generates a lot more heat. So I would actually use a wet bulb globe thermometer or temperature because you know how heat can dissipate a little bit more on the field that you're in. So for that, they price between like you can get one from Target for like $40. They at Home Depot they're about like $45 to $50. They can get real fancy and go up to like $250 to $300, but all you need is one. So if you and then for especially for schools, it actually is required. So, but these range between 30 to $50 to check for a wet bulb globe temperature.
Great, thank you. Because I think that they used to be much more expensive and cost was actually prohibitive for many of the actually even industry and occupational medicine for those measurements. And I know there are online calculations for determining as well. There's a question that says, there's basically an irony in recognizing health risk due to heat stress in athletes who are subjected to intense physiological measurements, surveillance and red lines during stressful physical activity compared to the rising risk to low income populations as climate change related temperatures increase. How can we translate this level of ambient temperature awareness and real time cautionary monitoring to our most vulnerable populations, which are involuntarily subjected to extreme heat risk? That is a great question. I think all of us, ask ourselves. Yeah, I mean, for myself as occupational medicine physician, one of the reasons why I'm here is that, and one of the reasons why we're all here, I think, is that we, hope for legislation that will help protect our most vulnerable populations, and that's why I put in. It says there's so much, and we could spend days talking about this. But for clinicians, all clinicians to document heat stress related codes, especially when you have these, when you have cardiovascular, respiratory, psychiatric, or psychological, or renal, even diabetes as well, that are influenced by climate related or heat, such as heat coding, so we can accurately assess the true impact of heat. It takes extra effort to put those codes on, but because some of them are just to identify, they're not the primary diagnosis coding. But we legislators won't understand when they ask for that information to understand the true scope of how heat is impacting our populations. So please to think about that. Myself and another physician that's part of PSR are going to look into see if we can figure out some way to make it easier or bundle this coding, so we can help document it and understand the true scope. Also, there is another question. Do the elementary schools have wet bulb globe thermometers? Do they monitor at elementary schools for heat for our outdoor activities?
That I am not sure because UIL technically only has jurisprudence on actual like sporting activities. So typically that's seventh grade and up. However, in elementary school, recess and physical activities is no more than less than an hour during the day. So I don't think so. But recess can be 15 to 30 minutes for elementary school. I do not have the answer to that, but I do not think so.
Thank you. Dr. Carter, are there geographical fertility rate difference within the US that you are aware of? Like as you compare the north to the south, do we see a decrease in fertility rates?
So this has been studied and there's not a difference. And that has to do with how well people are acclimatized to their heat. So that's why people on the East Coast are going to be affected at lower temperatures than people in the South or on the West Coast who are used to different heat. So it just depends. It's just like you with athletes, you have to undergo a process of getting used to it. And we are used to it in a different way than people on the East Coast. So no, it's not affecting the fertility rates, which means that just because it's cooler on the East Coast, they are not having better fertility rates than people in the South.
Yes, that makes sense. Also, what hydration solutions are recommended for athletes, and how are these same solutions to be used in occupational settings?
Can you repeat that?
What fluids to keep hydrated would you recommend for athletes, and how would you recommend the same solutions to be used in occupational settings? I can answer that part and
Yeah, I mean, water's fine. The If you want to consider a sports drink, I usually only recommend sports drinks for sports, not for like having it with lunch or anything, because it does have a lot of sugar. And then sugar, um, the thing is that when people sweat, they sweat out salt. So a lot of those like sports drinks do have electrolytes. Now, sometimes now they make sports drinks with like less sugar, more electrolytes. Some people have like electrolyte packets that they can put into their water or into their sports drink if they're feeling a little bit more crampy. Um, and this is the old, I guess this is the old school me here, but for like sports, you can even just do a shot of pickle juice, or I've had someone who's cramping in the high school field to where I go to the concession stand and ask them for that empty pickle jar. Let's bring that over here, and have this guy drink this for when they're really cramping, because pickle juice actually helps too.
Yep, that's good. That's good to hear. How about with pregnancy and hydration?
Sure. We also are concerned about electrolytes and the salt content. And so I like to encourage watermelon water because it's natural electrolytes, and coconut water because it's natural. I definitely do not encourage the sports drinks at all during pregnancy. In part also because they're in plastic bottles, and we have a lot of PFAS chemicals that get into them. So we like to stay as natural as possible during pregnancy.
Yes, and in the occupational medicine setting, we recommend, and when you're doing in the higher heat and higher physical demands, we recommend 8 ounces every 20 minutes, and water, primarily water. We don't recommend the sugary drinks, caffeinated drinks. And then maybe a more of a sports or electrolyte drink every 2 hours if it's extending beyond 2 hours, because we have so you can get that additional calories or electrolytes, because this is after acclimatization, because then you have already, you're already your electrolytes are already more balanced. You're not sweating out the additional salt and electrolytes after acclimatization. And also your body can only absorb so much at one time. And so that's why we have the 8 ounces every 20 minutes. So in the occupational setting, there's a lot of questions, so I don't mean to skip any here. Let's see. And then I saw some, and then some question about football players using drinking water to wet their shoes, and I guess to keep them cooler from the hot turf. And we're wondering, how hot does the turf actually get? And
Uh,
do
you
we, yeah.
you can fry an egg on those.
Oh,
It can get pretty hot at times, which is why like you can see it like with the turf. You can actually start. It's like when you go to Vegas, you can actually see the heat dissipate from the ground, and then going up. So with those, like that's where you really need to kind of um, one, limit the cooling, limit the time of practice, check the wet bulb globe temperature when you're playing on turf, um, and then kind of monitor accordingly.
is there any movement towards discouraging schools to converting their fields to turf?
That is going to be more of a difficult one, because like turf is actually cheap. It's easy, low cost to maintain. When you have a grass field, it's like a golf course. It has to be maintained daily. When you put two football teams together or a whole soccer team with cleats on grass, they will ruin a field pretty easily. There's also like patches and stuff like that, especially when it rains. So then like if you don't maintain it daily, there's going to be patching. You're actually more risk for like orthopedic injuries when you don't have a maintained grass field. So there are some private schools out there that actually have grass fields. But for a lot of like uh, independent school districts around Texas, it's mostly turf,
Okay.
unfortunately.
And yeah, unfortunately, people first. For Dr. Carter, do you think legislators are aware of the shocking trend in sperm counts you were highlighting?
No. Mm-mm.
Okay. So we need
Yeah.
to,
I
we need to,
don't think
yeah.
that they're aware of heat related anything. Well, except for athletes. Actually, I think they do pay attention to the athletes.
Yeah.
And
Yeah.
yeah, which is
Yeah.
good. We want them to pay attention to, we want them to pay attention. We'll welcome all the attention, but no,
Yeah,
don't.
and of note, and later on in the last half of this seminar, we will be talking about, the community and legislation and ways that we can solve this. Um, uh, When there's definitely comments, great comments that are being said. So I'm looking for the questions. Yeah, and I hear about people who have like syncopal episodes. Somebody saying about their eighth grader burned their hands on the turf in Houston, and it's only April. My son-in-law did have a syncopal episode in a parking lot, third-degree burns on his face until somebody was able to find him. It's just hot in the Dallas area. Uh, it sounds like schools need to move to indoor fields, but probably even more unaffordable, yeah, with cooling. Um, so let's see. I don't know if I'm missing any other questions. Are healthcare providers starting to provide heat education to pregnant patients?
Yes, in general, but we actually could do more to educate ourselves about how we talk to our patients. In Texas, we have the TCEQ will send out alerts the day before to let you know heat advisory times and ozone action days. And I try to get all of my pregnant patients to sign up for that so that they at least can plan the next day. But there's so much that we're required to do in such a short amount of time that oftentimes we don't get to some of the things that are crucial, but instead we're looking at just what's right in front of us instead of what they do when they walk outside of the office. So we also can improve ourselves for sure.
Right, right. Yeah, and part of what, in occupational medicine, of course, we're thinking about what their occupation is. We're all hurried in our practice, but we prior to the hot season, and then there are workers that work in hot indoor environments as well. So it can be all year. They're working near furnaces or on machine paced lines where they can't slow down. And take the necessary breaks that you discussed, Dr. Salapis, when they have those symptoms. But we try to identify persons that have increased risk for heat-related illness. We all can have a heat illness with the increased heat load on our bodies from the external, the metabolic, from the physical activity, but those with personal risk factors are at increased risk. And so if we can educate them, if they have a cardiovascular, respiratory, meet a certain age or pregnancy, et cetera, and talk to them and say that you need to be at in heightened awareness if you have XYZ symptoms, and it's hot and or physically active. You need to listen to those symptoms and stop and rest, cool yourself off, drink fluids, and if those symptoms don't abate in about 15 minutes, seek medical attention. So, and they need to hear that. They need to be advocates for themselves. And so, and then like with the medications that you discussed, being aware that certain medications may inhibit their ability to cool or may increase their metabolic rate. And so those are really important. Patients wouldn't know if if we're not educating them. So I encourage all of you to take that time or even put a questionnaire out that makes it easier for you, or even a handout that makes it easier for you. And if anybody wants some of that information, you can email me and I'm happy to provide that information to you. Let's see, are there any other I have ideas for how public health can support with the heat education for pregnant people. You're on mute. Yeah.
Yeah. Well, no, I would say whoever said if they have ideas, great. Let's bring it to the Texas Medical Association to help advocate for that, and let's go talk to legislators. I'm happy to go with you. Also, the American College of Obstetrics and Gynecology has a district that only encompasses Texas, and so we can get all of our medical organizations on board in addition to Physicians for Social Responsibility.
Mm-hmm. Yeah, and Nikki said communities need to be aware of funding that has been cut for programs to remember to ensure that cooling centers are active, and accessible water stations, and having rigorous state and municipal standards for heat stress prevention. Yes, absolutely. I think that, do we have any measures, proactive measuring of core body temperatures in a non-invasive way? Um, not, not
Yeah,
really.
there's only one true way to check a temperature.
Yeah.
The
And
way
it
I
is,
see it is save life.
yeah. What do you do as a medical director out in the field? Do you take core temperatures or do you rely on
Yeah,
symptoms that may be serious?
I tell my med students or any students that are with me, uh, this thermometer I have only goes one way, so don't use it any other way. Yes, and even like at the Houston Marathon, that's the only temperature that we check. Because to get a true assessment whether I need to put this kid in a tub or not is there. So every sideline bag that we do have concern, it is a rectal thermometer.
Okay. Okay. Yeah. And, and usually for an occupational setting, we're training their emergency responders and that so they may or may not have a medical director in the field, so we're relying on those symptoms. So they're not trained, emergency responders as their coworkers. So we use the buddy system as well, for especially for high heat. And then we say that, if you have, your buddy is acting confused, irrational, obviously if they have, faint or seizures, that, is definitely that, the 911 call, but go ahead, get, rest water, shade, call 911, immediately cool, throw water on them, take off any, PPE, start fanning them. But because you want that buddy to be watching out for you. People, when they're at that stage, they won't know to take themselves out of a hot environment. So they need to have that buddy system. And I am going to reach out to Dr. Cantu and and Becky to let me know if this is the time for us to um, take our 10-minute break, or are we out of time for our Q&A? So reaching out.
I'll leave that to Becky. Where are we at on time, Becky?
I think it's a good time for the break.
Break?
Okay, okay. So thank you all so much. This was a very, very interesting session, and our next will be on the health impacts on vulnerable adult populations and seniors. So we will have a 10-minute break and then come back for our next heat impacts on adult vulnerable populations. So we will see you back in 10 minutes and look forward to your return.
I think we're Just about ready to get started. Welcome to panel number 2. We've had a wonderful first panel, and we've got a great second panel planned for you in the area of extreme heat's impacts throughout the lifespan, vulnerable adult populations, and seniors. My name is Dr. Brett Perkison. I'm an associate professor at the University of Texas School of Public Health and Occupational Environmental Medicine. And it gives me great pleasure for us to introduce speakers who have subject matter experts in the area of populations experiencing homeless, agricultural workers, and geriatric populations. I'll just, each speaker has 20 minutes to talk, and I would ask the audience to please put questions in the chat. I'll be monitoring that chat. And at the conclusions of the three speakers, we'll open it up for questions, either taking yourself off mute or I'll ask questions from the chat. So I'll go ahead and, without further ado, introduce our speakers. Our first speaker is Dr. Mudit Gilatra. He's a family and addiction medicine physician and currently Associate Medical Director of Healthcare for the Homeless in Houston. He's worked with people who are homeless directly for the last 15 years and is passionate about providing the highest quality care to people without homes. Our number 2 speaker is Dr. Bethany Alcotter. She is the Chief Program Officer at the National Center of Farm Worker Health. She holds a BS in Community Health, an MPH in Epidemiology, and a PhD in our very own University of Texas Health Science Center's Occupational Epidemiology Department. Her areas of expertise include community-driven and participatory research and programming to prevent occupational health and safety issues for workers in both agricultural and construction industries. She lives in Austin, Texas, enjoys cooking on campfires, admiring pictographs and petroglyphs, and spending time with her children. And lastly, we have Dr. Angela Caddick, who is an academic geriatrician with a career focus on education and models of care. She's an associate professor in the section of geriatrics and palliative medicine at Baylor College of Medicine and serves as the Associate Chief of Staff of Education at the Michael E. DeBakey VA Medical Center. With no further ado, I will turn over to Dr. Gilatra to start us off.
Thank you so much. I appreciate that, Brett. Thanks for the introduction. And thanks everybody for letting me talk and joining in this today. I'm so excited to share some of the work that we do and how we think about heat related to people who are sleeping outside on the street. So we can get started. Next slide, please. So a little bit about our organization, just to start this off. I'm with Healthcare for the Homeless Houston, and we serve, we're the only federally qualified health center in Houston that exclusively serves people who are homeless. We do that through 3 brick and mortar locations. So this is our main clinic pictured here. And then we have another clinic downtown. Sorry, can you go back? Another clinic downtown and a third one in a family site. And then separately from our brick and mortar sites, we provide street medicine. So we are out on the street 5 days a week, checking in on people who are staying in encampments, staying under bridges, living in vehicles, kind of any place that's not meant for human habitation. And we provide medical services out there. We provide mental health services on the street, including psychiatry, medications, lab draws, wound care, anything to provide acute, but also primary care on the street, because as we all know, a lot of people who are sleeping outside have a lot of struggles with receiving healthcare the way the current healthcare systems are built. So that's just a little bit of background about us. So next slide, please. So a little bit of local context. Some of this you've gotten this morning already. Texas cities in general are really hot. And Houston is definitely no exception. It may even be one of the more extremes here. It's very common throughout the summer in Texas, and I use summer loosely because the Texas summer kind of just goes on forever, especially in Houston. But we have many, many days over 100 degrees where the heat index passes 100 degrees. We also have extremely high humidity in Houston in particular. And when things are really humid, the body is not able to cool as effectively. The main cooling mechanism is sweating. And that sweat, that liquid on your skin cannot evaporate effectively in high humidity. And that's why you feel a lot hotter. there, especially in cities, we see the urban heat island effect. And that's the idea that the way our cities are built actually increases heat. So the obvious thing, right, is we get rid of greenery and tree shade and all of that that absorbs heat, decreases temperature. But also a lot of the structures that we build trap heat, right? Our buildings trap heat, our concrete, our asphalt, dark colors, all of that trap heat and make areas hotter than they would be otherwise. And then we also generate a lot of heat in cities, right? So our cars, our vehicles, our industry, our power plants, especially in Houston, where we have so much oil processing and all of that, generate a ton of heat and raise the temperature of the area. So Houston is definitely known for that, the kind of urban heat island effect. As I mentioned before, our summer goes on forever. So at best case scenario, it's very hot from May through September. And, I have a little background on me. I have done street medicine in multiple cities around the country. I lived in Philadelphia for a long time, and in California for a long time. And in California, we basically saw no extreme weather. This was not a concern of ours. Most of our patients slept outside. It didn't have a lot of extreme weather impacts, except for wildfires. I guess we did see that. In Philadelphia, it was the opposite, right? Our cold season was so long that we see frostbite and all the injuries that come with cold. And in Houston, and in Texas cities in general, we see it more on the heat side. And then I'll talk a little bit more about this in a second, but our unsheltered populations are at disproportionate risk, I think, for very obvious reasons that we will go through. So next slide, please. So why this matters? Why are we talking about this? Our people experiencing homelessness are 200 times more likely than the average person to die from a heat-related illness. That is a crazy number to think about. And we don't see that kind of disproportionate increase when we talk about people experiencing homelessness with other diseases. They're 200 times more likely. And heat in general is the deadliest weather hazard. It's more deadly. We think about hurricanes, especially in Houston, and how deadly and dangerous they are. The heat is much more deadly than hurricanes. It is more deadly than what we see in the East Coast or northern parts of the United States, where we see severe cold weather for long periods. We still see more death with heat-related illnesses. The other challenge for people experiencing homelessness is they have no break from exposure. And we'll get into that a little bit and what does break from exposure look like. But in general, they have no way to remove themselves. So they are in, greater than 100-degree heat index temperatures, oftentimes, especially in the deep part of the summer in Houston, 24/7, where even in the middle of the night, often because of the humidity, the heat doesn't quite break. And they also are not able to follow what we would consider standard advice around heat. So we'll go into what that advice is, but they don't have access to the systems and tools to be able to do that. Next slide. Thanks. So the structures that exist make them vulnerable, especially in our cities. As I just mentioned, there's no escape from the heat. Oftentimes they have no place to get shade, to get into air conditioning, to get into a cooling center, or something like that. They have limited access to things that would make them more resilient to heat, limited access to water. And over time that has become harder and harder as there's been kind of shifting perspectives and politics around people who are homeless. There's limited access to shade. Oftentimes they're kicked out of parks and other areas where they would be able to at least get multiple degrees of cooler weather. I mentioned the urban heat island effect. So that oftentimes they're in cities, in downtown areas where that effect is more extreme. So while it may be 95 degrees out, in this urban heat island, it might be 5 degrees or more hotter. Oftentimes encampments where they are able to hide and stay will be in high heat zones. We have a number of patients who sleep under the freeway, which does allow them some shade, but they are often sleeping under the ramps. So I wish I had a picture of this, but they may have 2 feet of clearance. They're kind of laying down underneath and the road is 2 feet above them. And that creates this oven space where there's no breeze, there's no ability to cool down. And we have many, many people who kind of stay and sleep in those areas, those kinds of areas. So next slide. So barriers to getting cool. One, first, cooling centers need to open. They often, in Houston at least, over the last several years, have pulled back the availability of cooling centers. And I think this is seen in some other cities in Texas as well. So oftentimes they're not open, or their criteria for them to open is too strict. And we'll see that, you know, the heat index has to be over 95 degrees, or something that is already so extreme for someone who's going to be out in the environment for 24/7, right? For the entire day, weeks and weeks at a time. And then when they open, they often aren't in places that are accessible. So people may have to travel really far, leave their area, have no access to transportation. And if they have chronic diseases that make it hard for them to get around in the first place, the heat is going to make that harder, and even harder to get to a cooling center. One of the things that we've seen in Houston in particular is historically a lot of people will cool down in libraries and on public transportation. That'd be a good break. But we've seen at least public transportation as an option being pulled back like crazy, where you see a lot of enforcement now on, if you do not have a ticket, you're not allowed on the bus, even if it is extremely hot out and you just need a break from the heat. As an example, and the Metro Police have been pretty strict about that. There are certainly safety concerns in cooling centers that people have. A lot of shelters and cooling centers in the area don't have a lot of either security or protection, and people often are very concerned about going in there because they might feel that they are going to be attacked, and they feel maybe safer outside where they can get away from somebody. A lot of our clients have pets, and that makes sense because they are out there alone on the street, and dogs, I'll use that as an example, provide companionship, and especially when you are by yourself. Like, there's so much loneliness on the street and you want that companionship. They also provide safety, right? They alarm very effectively when someone's coming to the space. They can scare people off. People, for very understandable reasons, do not want to leave that dog behind, and that makes sense, right? And so a lot of times these centers do not allow people to bring their pets, and further, they don't allow them to bring their belongings. So oftentimes, as you see people who are homeless, they have maybe one grocery cart worth of stuff, and if they leave that somewhere, it will get stolen. So that can be a huge barrier to finding a place to cool down. Next slide. So the standard advice, what we always hear is, you know, when it's extremely hot out, is stay inside. And by definition, people who are homeless have no place to stay inside. We hear drink lots of water, and you know, there are many very kind restaurants and businesses that will allow people to get water. That is unfortunately the exception, not the norm. And so people who are homeless have very limited access to a way to easily hydrate. Using air condition, you know, again, by definition, you're stuck outside. That's not going to be available. If you are able to get into a cooling center, which is the last option, then you will be able to get some access to air conditioning. But again, they are often inaccessible, and we've seen more and more that the temperature requirements have gotten more extreme around opening them. Next slide. So clinical risk factors, I think this is talked about more later, so I didn't spend a lot of time on this, but certainly people who have cardiovascular disease are at much more risk for heat-related illness. People who have pulmonary disease are much more risk for an exacerbation of their COPD or asthma. We see a lot of chronic kidney disease, which makes them much more susceptible to water imbalance and dehydration. Certainly, we see that with diabetes as well. In particular, just slowing down for the last two bullets here, we see a significant amount of substance use in our population, and calling out alcohol and stimulants in particular, like people who are drinking heavily, one, are cognitively impaired in those moments, and they are not able to make the best possible decisions. Two, it is a significant dehydrator, right? So people who are drinking heavily are not well hydrated and much more susceptible to heat-related illness. In stimulants, we see people's ability to cool down impaired quite a bit. they're not able to vasodilate as effectively, their cardiac response is not as strong, and they're much more susceptible to heat stroke. And then in psychiatric illness, we'll talk about the illness itself and in a minute about the medications, but people who have psychiatric illness will, most significantly aren't able always to be able to make decisions to find a place to cool down. They might have significant levels of paranoia. We see this a lot, both in hot weather and in cold weather, where they're very paranoid and maybe don't feel safe, more so than the average individual, going inside to a cooling shelter. And finally, if they don't have capacity to make decisions, their illness is so impairing, they really do struggle to understand the risks and benefits of going inside versus staying outside and what that means for their life and their health. Next slide. So we think a lot about medications, especially in our patients who are sitting outside or sleeping outside. It's some medications that we see a lot of and the risks with them, antipsychotics. So they're incredibly effective for treatment of a lot of the diseases our patients experience. But when it comes to heat, they cause a lot of problems. Most significantly, they decrease somebody's ability to sweat and therefore to cool down. And then they also have an effect on the hypothalamus, which messes with your ability to temperature regulate in general, right? And you may not realize how hot your body has become and kind of cross the threshold between heat exhaustion and heat stroke. We also see, both with antipsychotics, but with other anticholinergics, all the anticholinergic effects that people have on their body. So reduce sweating for sure, right? Anticholinergics are significant on that. They also mess with your hypothalamus and decrease your ability to regulate your temperature. They reduce blood vessel dilatation, which is a huge way for the body to cool down. And so a lot of our patients who are on antipsychotics are getting the dual effect there, the anticholinergic effect, as well as the antipsychotic effect, which significantly increases their risk of heat stroke. We think a lot about diuretics. We have a lot of patients who have heart failure, who have hypertension, who are on diuretics, and they can significantly dehydrate you, and they also can cause a lot of electrolyte imbalance. And the other category we think a lot about is our patients who are on beta blockers, especially if they have heart failure. They also reduce your ability for your blood vessels to dilate. They blunt your heart rate response. So, when it's hot out, your heart starts to beat faster, to circulate more blood, to cool the body down. And they blunt that response. And they also decrease your sensation of thirst, right? So while you're getting hot, you aren't drinking as much water because you don't even realize that you need to. Next slide. So I'm running out of time, so I'm going to pick up the pace a little bit here. Sorry about that. Heat exhaustion, heat stroke. I'm not going to spend a lot of time in this. Except saying heat exhaustion is the level where your body is still trying to regulate, right? And so you're sweating a ton, you're feeling faint, you have a rapid heart rate, but it's starting to give out a little bit. Heat stroke is when your body kind of has started to give up its ability to cool down. And that's when your body temperature starts going up, the sweating has stopped, all of that. And this is what we're looking for in the field, especially when the weather starts to get pretty hot. Next slide. So what do we do? This is our street medicine van. We carry a ton of supplies with us. If we come on to somebody who is starting to show signs of heat exhaustion or just struggling with the heat in general, we encourage them to move to the shade. Oftentimes when you're in that space, you're starting to have trouble understanding why you're feeling the way you're feeling and starting to have trouble making decisions. So we'll help them get into the shade. We carry a lot of oral rehydration stuff with us, especially in the summer. So we have liquid IV. We carry, in the summer, we start carrying gallon jugs of water. So we give out a ton of water, but not giving out just one water bottle at a time. We'll give out whole gallons of water so people can have plenty of water, more so than they would think they would need. We have a lot of cooling tools. So we have a fridge in the van and we keep very cold water. We keep ice packs, cold wet cloths, all of that to help people get their temperature to reset. And then we'll usually hang out with them for quite a while and see, make sure they start feeling better and they have a plan in case they don't start feeling better. Next slide. Definitely when people start showing signs of heat exhaustion, we escalate very quickly, and that's when we'll get EMS involved. So if they have a change in mental status, if they're no longer able to eat, any other signs of heat stroke, we'll quickly and rapidly get them into the emergency room where they can get properly cooled. Next slide. So I mentioned some of these already, but our main prevention strategies, we give out a ton of water. So important. We give out electrolytes with it, all of that. We, starting in the winter, I mean, in the summer, we'll start packing cooling kits. We kind of do the opposite in the winter. So that we'll have stuff like electrolytes and all that, but also just like fabric and cloths that they can use, put water on and cool their head, things like that. We'll also give out information about if cooling centers do open, where all of them are, and talk to people about what the closest one is to them. We will identify high-risk patients, kind of give them a heads up that they're at more risk, they need to be more careful. And then I mentioned medications earlier. We are very careful about the meds that we prescribe. So we'll talk a lot about this on street medicine when we're thinking about getting somebody on a diuretic for their blood pressure. We're like, well, is that really the best choice for this person? What is their ability to cool down, stay hydrated, things like that, for example. Next slide. System level interventions, things we can advocate for that are often missing in Houston, at least, and I know a lot of the other Texas cities, is it'd be great to have public places where people can hydrate. A lot of parks and stuff do not have water fountains and do not have any place to get water. Shade infrastructure in general. I know a lot of cities, thankfully, are like installing more park space, planting more trees, and we need to see that grow. The ultimate treatment is housing, right? And we don't need to spend much time on that. It's a treatment for a lot of things, for people experiencing homelessness, certainly for their ability to survive in heat. And I think this is my last slide coming up. Next one. So what clinicians we can do, we can screen for heat risk, review medications, we talked about that, follow high-risk patients, advocate for structural solutions. I think the other big thing we can do is safety planning with our patients. So we do quite a bit of this, and as you all are seeing patients or talking to people, is, you know, what is their plan when the weather gets hot? Do they know where the cooling center is? Do they have a buddy, someone who's going to check in on them and be able to check in with that person too, and kind of share the stress of being out in the heat and so on. So next slide. So that's it. Sorry I had to rush the end there, but if people have any questions, I think there's some question and answer coming. And feel free to email me as well. Thank you.
Thank you so much, Dr. Galotra. What a wonderful overview, and what a challenging population for us to reach out and treat. It's given us a lot of good ideas, a lot of opportunities for research and advocacy and policy. Please put in questions. We've been enjoying the dialogue going on in the chat during this talk, and if you'd like to convert those to questions, feel free to please put that in. I'll now turn it over to Dr. Bethany Alcotter. Thank you.
Thank you. I'm so happy to be here. All right, we can go ahead and get started. And fair warning, I have quite a few extra slides in here that I'll skip, but they're just in here kind of as a reference for any audience members. So I work at the National Center for Farm Worker Health. We do national education and collaborative programming with healthcare providers and community-based organizations around the country, but we're based in Central Texas, and we do a lot of kind of place-based work with farm workers, refugees, immigrants, and migrants here in Texas, as well as in North Carolina. So I'm going to talk a little bit about outdoor workers, and by outdoor workers, I'm focusing specifically on people who are employed in agriculture, construction, and landscaping. There's other people who spend a lot of time outside, but people in those industries have a lot in common, especially in terms of vulnerabilities when it comes to heat-related illnesses. All right, you can go to the next slide. Thank you. So first, let's talk a little bit about who's in this labor force and kind of their overall labor structure. This slide is focused on people in agriculture and construction, as well as many of the slides, because there's very little information available about people who work in landscaping. But I'll add my anecdotal experience when it's relevant. So nationally, if you can back up, sorry, nationally, about 1 in 4 people in those industries are immigrants, usually from Mexico or from Central American countries. Um, that's a caveat though, because in Texas, it's probably much higher. The estimates vary a lot, especially when you're honing in on who you're talking about in those industries. But for the people who are working out in the fields, out on the construction sites, that proportion gets much higher. It's probably more like 70 to 80% of people who are working outside in those industries are immigrants. And the estimates are that about half of those people don't have an immigration status, they're undocumented. You can go to the next slide. Most people working in these industries are men. There are women who work there too, but there is a lot higher proportion of men in these industries. But beyond that, the diversity is huge. Even though most people are coming from Latin American countries, there's a huge amount of diversity in terms of what types of socioeconomic backgrounds they come from, cultural and ethnic backgrounds, and what languages they speak. So we see all the time in all three of those industries, there are a lot of people coming from Mesoamerican indigenous communities, from southern Mexico, from central Mexico, from Guatemala, and other places. And a lot of those individuals don't start learning Spanish until they come to the United States. So lots of public health programming implications just because it's such a diverse group of people. Go ahead. A few notes on their overall work conditions. Obviously, they're working outside, and if it's in the south, it's very hot, it's very humid. A bigger concern for exposure in these industries is the long work hours. In farming, you'll see 80 to 100 hours a week being pretty common. In construction, 60 to 80 hours a week is very common. Landscaping tends to have the lowest with about 40 to 60 hours a week, but overall, it's a huge amount of time working outside in direct sunlight, often without breaks or very few breaks. One point that I will belabor a little bit is about labor contracting chains, because this has so many implications for how safety training and public health programs are implemented and how laws are implemented, enforced, and how accountability is implemented. So go ahead and go to the next slide. What I see from my 12 plus years as being kind of a go-between person between government agencies, healthcare systems, et cetera, and workers in these industries is that people who are trying to implement programs to improve the lives of these workers have an assumption that information will flow down these contracting chains and that power will flow up, whereas really it's the complete opposite. The information needs to kind of start at the bottom in terms of what types of actions people need to take, how much water they need to drink, what types of food they need to eat to replace electrolytes. All that information needs to start directly with the workers. It doesn't trickle down. And then on the other side, all the stuff about power that involves power, like how often you can take a rest break, that has to come from the top. The workers at the bottom do not have the agency, by and large, in most companies to implement that type of change. So this is one example. There's a couple of examples in here of different types of kind of labor structures, which are really reflective of the power dynamics that people experience. So in this example, we have, a farm producer who hires a labor contractor. That labor contractor is hiring crew leaders, and then those crew leaders are either just supervising field crews or they're actually hiring them. So you can have 2 or 3 levels of employers just on one fairly small farm. And if you have a patient show up who's on one of those field crews and you're telling them that they need to take more breaks, they need to sit in the shade, etc., they won't have the agency to do that. It'll have to be, there has to be some consensus from all these different levels of employers in order for those changes to take place. You can go ahead. This is just another example of a fairly similar structure that happens in ag and landscaping, where you have contracted visa workers from Mexico and from Central American countries who are all employed by two levels of an employer. You can go ahead. You can get really complex chains in farming where you have this is an old plantation style system of labor structure that we see all the time all over the United States. And mayordomo is a Spanish term from the Mexican plantation system, which was called haciendas. And a mayordomo was a trusted worker who worked for the plantation owner and had kind of total control over the whole plantation. That same labor structure still exists on farms here in Texas, and that mayordomo is the one who controls how everything happens on the farm. So in this type of labor structure, especially, workers really don't have agency to change how their workday is laid out. Go ahead. One more example here. In construction, it's a little different, and those of you who work in urban cities might encounter construction workers a lot more. Construction is very broken up by this specialty type of work. So you'll have a developer who funds a project, a general contractor who's in charge of everything, kind of like the mayordomo, and then you'll have the specialty contractors based on what type of work they do. And those specialty contractors can have a simple system of employment, or they can have very complex chains of contracting below them. It just really kind of varies. So all really important to consider when we're thinking about public health programming for those workers or just individual interactions with those workers. Go ahead, you can skip this slide. I like to honor the people who have experienced things they never should have experienced, because these heat stress deaths that happen in these industries are always preventable, as I'm sure it's the same way for the unhoused population. There's no need for people to die from this. Workers in agriculture, forestry, and fishing are about 35 times more likely to die from a heat stroke compared to workers in other industries. Construction also has a very elevated risk of death from heat stroke. And Rowan de Granillo was a young man who was 25 years old when he died from heat stroke working building houses in Dallas. And his family, I like to honor them when I do a presentation about heat stress, because his family was so deeply impacted by his death on the work site that they became very involved in a movement to pass a rest break ordinance for construction workers in the city of Dallas. And they successfully did that until the governor overrode that, which is a long story. Okay, you can go to the next slide. I have a few slides that you're welcome to use in educational sessions with people. I did a really short pilot study with construction workers in Houston and Austin a couple of years ago. You can go to the next slide. This was a small study that I did. I was supposed to do it as a doctoral student and did it a little late because of the pandemic, but it was so troubling that I ended up taking a lot of photos and using it for a lot of educational tools. But the study was with just 16 construction workers in the two cities. I worked with these small crews who were doing roofing, remodeling, and sheetrock, and I met with them before their work shift and after, and we did a really simple urine dipstick analysis, looked at protein in their urine with a DCA analyzer. And then they told me about some basic heat stress symptoms they might have experienced, fluid intake, and things like that through a survey at the end of each day. Go ahead. So this was in the summer. This was in June of 2022 that this took place. It was very hot for most of the study. And their urine was so dark that it was just very alarming. And luckily I had at the UT School of Public Health, I had a mentor on the study who was also a physician, who helped me work through some of this. And and help get one of them into the ER and things like that. But anyhow, all of these people, you can go to the next slide, all of them had severely dehydrated urine samples based on the dipstick analysis. I was even checking my urine because I was worried that the dipstick analysis was off or something. I was never even mildly dehydrated, but these guys were so severely dehydrated even at the start of the workday. I was just ended up buying them water and Gatorade and stuff because they were starting each day so dehydrated. Of those 16 people, 75% were reporting that they had one or more symptoms of a heat-related illness. Fatigue and headaches were their most commonly reported symptoms. 44% were showing blood in the urine on the dipstick analysis. I wasn't able to confirm it in that pilot study because I hadn't planned to see it in such a small sample. And then 12% were showing some protein in the urine. We ended up working with the School of Public Health to make this flyer. What I was finding is that workers had no idea how much water they should be drinking during the day. Obviously, that's different for everyone, but these guys were drinking about a liter a day, working in over 100-degree heat for 10 hours a day. So we ended up making this flyer in English, Spanish, and a couple other languages, giving guidelines on how much water to drink, and then also information about how to replace electrolytes with, through fluids, different types of fluids, and then different types of culturally acceptable foods that are easy for people to eat doing this type of work. Next slide, please. You can skip this slide. There's a lot of practical issues in the field, but I want to highlight just two, and the rest are kind of references. You can go to the next slide. One is that this is experiencing heat and dehydration in this way, I think has an enormous and unmeasured mental health impact on the people who are experiencing this. So this is a quote that I had from one of the participants in the pilot is, "We don't get water, they even give water to their dogs." And this is some variation of this I've heard many times from many different outdoor workers, and the lack of drinking water or the lack of time to drink water is such a basic, it's just such a basic right, and people aren't getting it in so many places that it's dehumanizing. It's just, we think of the heat stress and the physical risk, but it's a dehumanizing experience for these workers. Go ahead. You can skip this. I have some key points for talking to workers that I think are fairly effective. You can skip it though. It's just a reference. There's a lot of things to think about because this is such a heavily male industry, and I think men in these industries are very driven to provide for their families. They want to make sure that they do a good job, and there's so many, they're not necessarily thinking about their own long-term health or their own longevity. And so I think it's really critical to encourage men to support each other, and to encourage each other to drink water and to take care of their bodies. Go ahead. You can skip. Okay, here. This is the last point I'll make, and I'll stop because I think I'm also very close to time. This point about these workers essentially functioning as athletes in the day is huge. It's huge for the workers themselves, it's huge for their employers, and it's huge, I think, for public health programmers. So they're burning, there's almost no data about this, how many calories these guys are burning at work. There's one study that was done in the Midwest with farm workers, and they found that those guys were burning 350 to 540 calories per hour during the workday. That's a huge calorie burn, and these guys are being told to eat 2,000 calories a day, and they're not being educated about the electrolytes that they need to replace. So this whole idea of kind of connecting their work as like an athletic performance is really big, and I would love to do a study on how many calories people are burning in these different industries if anyone wants to collaborate on that. So I'll stop there. You can jump to the slide with my email, and we'll go to the next presenter.
Thanks so much, Dr. Alcotter. One of the comments in the chat was if you did publish that work on that pilot project you did, there was a request for that. I don't know if Dr. McCarthy's posted it, but she and I have published some work on heat stress as well. So we'd be glad to share that with the audience. Really great talk. And our last presenter is Dr. Angela Caddick at Baylor College of Medicine. I'll turn it over to Dr. Caddick.
Thank you so much. And it's really an honor to be here today and following these remarkable speakers. So we can just move on to the next slide. I will be speaking with you all today about heat issues among older adults. I think you are going to hear many overlaps to our prior talks, but with kind of a unique spin for this patient population. So if we move to the next slide. Really at the conclusion of my 20 minutes, I hope that all of us will be able to explain why older adults are especially vulnerable to extreme heat, identify the clinical implications for these individuals, and then I really do want to spend kind of at least half of our time together thinking about how we can apply strategies to prevent heat-related illness in this population. So if you can move on. I'm just going to let this graphic set here for a moment. This is from a New England Journal of Medicine paper. And I think for each of the amazing talks we've heard this morning, we could do an exercise where we kind of go through and click off which of these factors are applicable to each of the patient populations that we have discussed. But if we go to the next slide, you'll see I've kind of done that work for us as it pertains to older adults, and just keep clicking. I'm sorry, I've got some animation here. So boy, we're getting we're getting a lot of circles, right, as we think about older adults. And while you can see that, many of those are individual susceptibility, and we're going to dive into those. There also are sociocultural factors as well as just heat exposure, with many of our older adults in the US living in the urban heat islands that we've already spoken about this morning. So if you can move to the next slide. I just want to start off by thinking about some physiologic changes in older adults. If you get a geriatrician around, this is a topic that's near and dear to our hearts. And we'd like to say that older adults are not just an older version of middle age. We really do change physiologically as we age. So with aging, we have an impaired cutaneous vasodilation. You've heard that discussed in other contexts. But just as an example, in older adults, their sweating and vasodilation is reduced 56% on their arms and 82% on their back compared to younger individuals. So just, think of that as they're out in the heat. They have, in general, sweating dysfunction. They have cardiovascular limitations. Their plasma volume lowers as they age. They have decreased cardiac output and reduced blood flow to the skin. And then in older adults, there's a significantly diminished thirst drive. There's a very famous study that people love to trot out that's, it's quite old at this time, but there's no change, where they deprived younger individuals and older individuals of fluids. And at the end, while the younger individuals were very thirsty, the older adults had no thirst drive. And all of these really add up. And you can see that during a simulated heat wave in a study that was done, younger adults had a core temperature that was nearly double that of younger adults. So very, very high risk. If we move to the next slide. This increases even more in our older adults with coexisting conditions, and that's defined as having 2 or more chronic conditions. And you can see that here in our Medicare beneficiaries. And for adults 85 years of age and older, 83% are going to meet that definition. So I've given you some of the most common on this slide. I want to start with our psychiatric illnesses. We've heard about those already from some of our other speakers, but these have the strongest medical comorbidity associated with heat-related deaths. And in older adults, that's an odd ratio of 3.6, so more than tripling the risk of death. Of course, cardiovascular disease, something that's very, very common among older adults, chronic kidney disease, pulmonary disease, diabetes, are neurologic disorders. So be that dementia, delirium, Parkinson's disease, they are all going to have impaired behavioral thermoregulation, and then simple mobility limitations, which, may not be the first thing that pops to mind. But if you are limited in your mobility, if you cannot get up without assistance, to get to water, to get to be able to cool yourself off. This becomes a major issue during heat-related periods. So we'll move to the next slide. And then to think a moment to touch on medication effects. And I won't go through this entire diagram with all of you, but it'll be here as a reference. But we know that among our Medicare beneficiaries, there is an up to 33% increase in heat-related hospitalizations across medication classes. And this is throughout our warmer months, not just during heat waves. So, here in Houston, from April until really mid-October, we are seeing these increased hospitalizations. And the things that they are most commonly presenting with include dehydration, especially in the setting of our diuretics, electrolyte disorders, renal failure, UTI, and heat stroke. And, I just want to point out, and we've heard about this earlier today, but anticholinergic medication, something we really think a lot about in older adults. And in fact, every patient I see in clinic, I'm calculating their anticholinergic burden score and thinking about how I can decrease that. And I do that for a variety of reasons. We know it can contribute to confusion, gait instability, but another issue is their susceptibility to heat-related illness. We can go to the next slide. So I really want to take a bit of time with the psychosocial factors. I think that's something that maybe we aren't always thinking about as we're seeing older adults in a clinical setting because, they're not out doing sports, they're not working in an outdoor job. Many of them are not unhoused. Of course, that is a concern for some, but there's still a lot of psychosocial factors we have to take into account. And the first, and to me, maybe one of the most important is social isolation. We know our country is facing really a loneliness pandemic. Families look very different than they did 100 years ago. Many of our older adults are not living near family members. And this is really one of the most significant risk factors for heat-related illness. And in fact, individuals without a support system had a dramatically elevated heat wave mortality, and you can see the risk on the slide. Second, housing status, housing quality, especially in our cities, but this is also the case in rural areas. Many of them are living in older homes. There's poor insulation. They may be without air conditioning. Their windows may be stuck and not open. They could live on upper floors of high-rise buildings. And again, they have limited access to cooling centers. We've heard that regarding the unhoused population, but we see the same thing in older adults who may not be able to travel to cooling centers, who may feel uncomfortable or scared of what could happen to them in a cooling center, or just have a real reluctance to leave their home for a variety of reasons. And then we know that a quarter of all older adults in the United States live in urban heat islands. This is particularly the case in low-income communities where I thought this was a staggering statistic. They can be 41 degrees warmer than in wealthier communities where there is more green space. And then our high urban heat island areas account for 25% of total heat-related cardiovascular burden versus just 4% for our low urban heat index areas. And I just an antidote I hear, every single summer from patients in my clinic is how different things used to be here in Houston. And they're kind of reminiscing when they were kids growing up in this area, 80 years ago, and how they would play outside all day. And the heat was really tolerable. And there was so much more green space and so many more trees, and just how much things have changed just over their lifetime. And I think we're seeing that reflected in all of these psychosocial factors. We can go on to the next slide. So thinking about morbidity and mortality among older adults, we know that heat-related mortality has increased in individuals 65 years of age and older by 54% just over the last 20 years. In older adults, classic heat stroke actually has a mortality rate approaching 80% without prompt treatment. And you can see in emergency departments, the case fatality rate is, for some reason, not showing, but it's 9.4 per 10,000 visits. And then I just want to bring your attention to the graph there. This is a heat-related deaths in Europe during the summer of 2022. And you can see that tremendous spike, especially among our oldest old, those 80 years of age and older. And then I won't go through this graph. This is really here for your reference. But again, this is social conditions and general health risk factors for all causes of death during heat waves. And you can see that almost all of these are really applicable to older adults. So we can go to the next slide. So what are some of the clinical implications of this? This was a study that took 85% of all Medicare enrollees, so 23.7 million older adults. So really a remarkably large study that gives us some great insight. And what they found is while risks were largest on the day or days of heat wave, they remained statistically elevated for the next 1 to 5 subsequent days. So if we take a place like Austin or Houston, we can imagine there may be some variation, but this is really elevated throughout the summer. And here you can see what they were admitted with. So fluid and electrolyte disorders, renal failure, urinary tract infections, sepsis, and then heat stroke and other external causes. So a huge issue during the summers here in Texas, affecting so many of our older adults in, the hospitalizations that we're seeing across our state. Next slide. So, what can we do about this? What are some preventive strategies for heat-related illnesses in older adults? And this is something I've begun thinking more and more about as my career has progressed. But, I think as we've mentioned before, we can all do a better job in educating our patients and educating their care partners and finding ways to work this into busy practices. So I'm going to delve into most of these, but with older adults, really thinking about medication reviews, doing a risk assessment, having a monitoring plan, talking to them about how to cool off, some behavioral interventions. And then I want to end by just touching on a couple of population level interventions. So next slide. So first, we really have to educate. I don't think most of our older adults and their care partners are coming in really thinking about the risk of the heat here in Texas. And we need to discuss that with them. We need to educate them about the signs and symptoms of heat-related illnesses, what they need to be looking out for, and then how to reduce those risks and when they really do need to seek medical attention. We want to review what their plan would be, including how to access cooling measures, including air conditioners and fans, and having an emergency plan in the event of a power outage. I think we've all experienced that here in Texas. I know, here in Houston, I'm not native to this area and have probably had more power outages in the 12 years I've lived here than I have in the entirety of my former life. So, really being proactive about thinking how they can prepare for that. And then it takes a village. We really need to engage everyone from our social workers and our community partners and related services to assist in arranging for safety checks and thinking about how to help them access cooling centers, and then really educating older adults and their care partners on how to monitor heat risk. And I just gave one example of where they could do that on this slide. And we can move on. We want to think about medication adjustment, and I know we heard about that already with our unhoused population. It's always best to do a preseason medication review. We don't want to wait until there's a crisis during a heat wave to think about doing these medication adjustments. You can see here some of the more common medications that we're going to want to think about. Of course, this is not an exhaustive list. Thinking about diuretics, though, if that's something that really does need to be used, what are some aggressive hydration strategies, how we can work with older adults to monitor for orthostasis and do frequent lab checks to ensure that they're not developing electrolyte abnormalities. If there is a reason we really need to be using a non-selective beta blocker where they're going to have a limited cardiovascular compensation during heat stress, we need to have increased monitoring. I already mentioned our anticholinergics, where you're going to have decreased sweat production and impaired thermoregulation, already an issue with normal aging. Here, we really want to de-prescribe those medications if at all possible. And then our psychiatric medications, which can be very challenging. There are many instances where it's really not feasible to de-prescribe those, but we need to be thinking very carefully about a risk-benefit assessment and what safeguards we can put in place if those medications do need to be continued. Next slide, please. And then working with our older adults to really think about how they can implement environmental cooling strategies. This is often going to involve their care partners. Of course, air conditioning is the most effective, but that may not always be available. Important to keep in mind that fans can actually be detrimental in dry conditions and become ineffective when it's greater than 99 degrees Fahrenheit. If using, they need to be kind of self-dousing with themselves or wearing wet clothing so that they can cool off more effectively. Other ways this can be implemented: rooftop sprinklers, outdoor sunshades, heat reflective window glass. This is something that is often discussed, especially in long-term care facilities or personal care homes, where it's not as regulated in personal care homes. They may not have as effective air conditioning, and these are other measures that can be put into place. Evaporative coolers, and then, of course, excuse me, adequate natural ventilation. Next slide. Hydration is a huge issue in our older population. As I mentioned, they don't have a thirst mechanism like younger adults. We really want to encourage them to drink non-caffeinated fluids on a regular basis and not wait for that thirst, which will likely not come. This is especially a concern for our individuals with functional or cognitive impairment, which limits their independent access to fluids. It is critical that we are engaging their care partners to make sure that they are receiving adequate fluids and having that available to them. And then in individuals who are often reluctant to drink adequate fluid, we need to think of extra ways to get that fluid into them through foods. I talk a lot about fruits. Melons are great, grapes are great, but that's something that many older adults really find appealing, especially those with cognitive impairment, because they can be very sweet. So that's a great way to get in extra fluids. The same for popsicles. Probably not as appealing during a heat wave, but I talk a lot about broth-based soups, especially like your chicken noodle, which has an amount of salt in the broth. So really being creative and finding ways to get fluid in, realizing they probably are not going to meet their fluid goals through simple drinking alone. Next slide, please. Some other behavioral interventions: we want to limit their physical activity during the warmest part of the day. I think with the best of intentions, a lot of family caregivers want loved ones to be outside, especially those with cognitive impairment. It's often kind of a break to get them outside and sitting on the porch, but reminding them that we want to limit that to, early morning hours or later in the evening, and to avoid during heat waves. Wearing lightweight, loose-fitting clothing. I often see individuals coming here to the Houston VA wearing very heavy clothing, even on our hottest days, and understanding our air conditioning here is much colder than it needs to be, but trying to make sure at least when they're outside, they're wearing looser fitting clothing and then carrying that jacket or sweater just to put on in air conditioned buildings. Using cool showers, water saturated cotton t-shirts, iced towels, and then of course encouraging those cool foods which can help cool them off from the inside. Next slide. And then monitoring is so important. We need to be doing frequent safety checks. This is just an example of a retrospective study which was done in Rome, but I thought it was so powerful. They had 3 different areas in Rome where they put in place an isolation reduction program. And really, it was not a lot. It was a phone call from a volunteer at a maximum frequency of once every 2 weeks. They chatted with the older adults about how to develop a care plan for heat. And if needed during heat waves, they would do a home visit, bringing medication or food. And you can see this simple program decreased excess heat wave mortality by 56% in older adults over age 80. So it was really, really powerful, and something I can envision, neighborhoods putting in place for older adults in their community who are isolated. Next slide. And then just to touch on population strategies, I know these have been discussed, thinking about going to libraries and churches, check-ins for our high-risk patients, provision of air conditioners to high-risk patients that's available through programs such as the Program for All-Inclusive Care of the Elderly. And then really a shout out to our Texas area agencies on aging. They have multiple different services depending on the AAA that they are able to provide to older adults. to assist during extreme heat. And the next slide is my last slide. I think I will just skip this one because I know I'm at time and I want to allow time for Q&A. So thank you all.
Thank you so much to all the speakers for staying on schedule too. Boy, you made my job easy. Yeah, really appreciate it. What a wonderful group of speakers. Just a couple of comments before we start with question and answers. Dr. McCarthy has put a PDF of a presentation or publication we did on heat stress in the chat. Dr. Alcotter has put her email in that if you'd like her poster presentation of the pilot project, she can send that to you directly. And if others have, and then others have put in videos and other reference material for you to take a look at. The other thing is that, just as the one thing that all the three presentations have in common to me is that that all of these require systems in place that are beyond the traditional patient-physician relationship. They require non-medical drivers of health. They require referrals, just like you would refer your patients with diabetes to dietitians. This is going to require referrals to cooling centers and other resources for people. And the other thing is that the systems that we have in place that have worked in the past aren't going to work in the future. Areas of the country that didn't have problems with heat stress and now have problems with it. Seasons are longer. So I think as physicians, as providers in the audience, that we need to provide this information we're seeing from our patients directly to policyholders on local and state levels to let them know what's going on, because old systems are not working. So I will pause there, and yeah, let's just open it up. If people would like to take themselves off mute or put questions in the chat, I will be moderating that. I guess while people are thinking about what to put in there is, I guess I'll start off with a question for Dr. Caddick. With heat waves occurring in Texas, we've talked about older populations. Have you had any experience with rural populations, kind of older rural populations that who may be out? There's less resources that they have. There's not cooling centers. Just anything that you can provide to our audience about that.
I think those are, an especially vulnerable population, and we do deal with that population frequently from the VA. I don't know how familiar folks are with the Houston VA, but we span all the way, to Galveston, up to Beaumont, up to Lufkin. So we have very rural community-based clinics that we cover up to, 3.5 hours away. And you're absolutely right, Dr. Perkinson. They are especially vulnerable because all the resources are often not there. And it becomes much more imperative that they do have some sort of support system because they're not going to have that public infrastructure to go to. So really checking in with them. The VA, we do safety checks during extreme weather, including heat and hurricanes. So actually for our vulnerable older adults, there's a team that's reaching out and calling them, making sure that they have access to fluids, making sure if their power is still on, and if their power goes out, where are you going to go? Do you need help with transport to get you there? We've driven trucks with water out to these areas, but this is a very VA specific thing. So it's not solving the issue from a more systemic level, which I think is the real concern and the need for public health. And then I just will add, I saw someone had asked how we calculate an anticholinergic burden if there was a particular tool. So I did drop that in the chat. It's called the ACB calculator. I can't recommend it enough. I'm not paid. It was a free tool that was put up. You can just Google it and it gives you a score. Anything over 3 is considered a significant anticholinergic risk, but we really like to see older adults at a 1 or maybe a 2. So hope that's helpful.
No, that's great. I was not aware of that calculator, so that's really great information. There was the question in the chat from Ricardo Garay, and this is really for anyone that would care to chime in of our speakers or others. Are there any current research collaboration opportunities in Texas to bring change? And Ricardo, if you'd like to elaborate on that, feel free to.
Yeah, thank you, Brett. I was just wanting to know, especially if there was any advocacy work with this research, especially with some of the stuff that was mentioned around what happened at the Texas legislature in 2023 that I think really made it difficult to provide protection for workers. So I was wondering if there was any organizing, any research being done to be able to get ahead of this and create some change at that policy level.
Great question. I'll let our speakers, if they'd like to comment. I have a few comments regarding the OSHA federal standard, but if you guys would like to chime in first, please.
From the labor side, I would say after years of working on local policy change and some federal, I have maybe the controversial personal opinion that that's not the most effective route to go, especially now, and that working to change employer mindset is more effective and faster, and will reach more vulnerable people, which is why I think demonstrating how taking care of employees' health will only help productivity and the bottom line is actually a lot more effective. I think there are policy changes that could be done, but right now it's OSHA is so limited and the state is so unfriendly to those types of policies that I think working within the industry overall is kind of proving to be more effective at actually helping people in those industries.
Yeah. Yeah, and I'd also like to add that there's a couple of research studies that I included, one that Brett and I worked on together, and then there's a follow-up on an initial study in 2019 that was also included in the promulgation for an OSHA heat standard that's in the Federal Register right now. It's not in full effect, but it is up there as a proposed standard. So many states right now, we have 7 states, I think 8 now. Virginia just enacted a heat standard. So we have states that have their own OSHA state legislation that are adopting heat standards. And I think in 2025, there were 18 other states that are proposing heat standards. So but I think, as you said, Bethany, that employers, we need the research and just their knowledge, the employers to be educated to understand how keeping your patients healthy, doing these preventive measures help their employees to be more productive and decrease their cost. And so the one study, basically just implementing a heat illness prevention program at a municipality to help protect workers, went back and looked at the data retrospectively, and we decreased our illnesses and cut average costs by 2/3. And so, in that decade, and at that time, it was the hottest decade on record. At the last 2 years, we had no heat-related illnesses in this outdoor worker population. So, it was, this employers and municipality weren't concerned about reporting their injuries, but they were concerned about their cost. And so it's very powerful evidence that providing heat preventive illness programs in your employee population will not only decrease serious illness in your employee population, but also increase the productivity and decrease cost. And there's other studies to help support that study. So it's even without legislation, it just makes sense. And of course, we as just human beings, we want our fathers, husbands, and most of these are male, just our family members to come home after work.
Thank you. Yeah, no, all good information. I also mentioned there was a federal heat standard to kind of elaborate on Dr. McCarthy's statement that we was accepting comments all the way up until December of last year of 2024. And then with the new administration, the federal heat standard was struck down. But those comments are still there. There was over 43,000 comments about heat stress, a federal heat stress standard. So it's going to come back, and you're just continuing to kind of follow the news because there are vehicles for your input on it. The other thing is that, in occupational medicine, our specialty, we're sort of trying to think about productivity that Dr. Alcotter meant. And so if you and as physicians, we're really not trained to think that way. We think about health, but really, if you can begin to talk to people about how much time they missed, how much loss of productivity, those kinds of languages that were not traditionally taken in our history is actually very useful to get legislation moved. And the nice thing is that good health is also good productivity, and so it works together. Last thing I'll just mention is that regarding claims, there was a question in the chat about claims, is that as a provider, when you are documenting heat stress, a lot of heat stress is very much underdocumented. When you look at some of the claims data, we're looking at some claims data right now. We tend to only say heat stroke when somebody's had a fatal or near fatal condition. There's a lot of more milder heat stress cases that get diagnosed as dehydration or faint dizziness. As clinicians, if you see that, documenting in the ICD-10 codes gives epidemiologists and others that are looking at claims data more power to show the true extent that heat stress is affecting our population. So, and we're trying to come up with mechanisms like bundling of codes and incentives for doing that. But while we're working on that, incorporating that in your own practice, incorporating that into your own histories can help a lot. Other questions for the audience? Other comments? I have a question maybe for Dr. Galotra, and this is a little bit different line of thought. Is that I am struck by the antipsychotics and their effect of making people more vulnerable to heat stress. Have you seen any information in the literature or from pharmaceutical companies that they're acknowledging that as heat temperatures rise, that there's more effort, that are being sort of designed new classes of medications in that area?
Thank you for the question. Not that I have seen personally. It's possible that they are thinking about it, and I'm just not up to date on all of that evidence there. What we and our psychiatry team has done a lot of is for our patients who require antipsychotics, and some of them that have more propensity to anticholinergic effects or temperature regulation effects, is to try to transition them off of those medications and onto different medications. And it's tricky. I think as Dr. Caddick said earlier, a lot of times patients need those medicines. They're so critical, and there's maybe a very narrow window of medications that really decrease their psychosis. And so it's a risk-benefit equation of just like, can you pull back a little bit to make it a little safer for them to be outside, and what does that actually look like? So a very tricky balance for sure.
Yeah, I can't imagine, just the difficulty in managing patients like that. Just another question for you is for the physicians in private practice in the audience, how can they best support organizations like yourself? Is there a way other than volunteering physically? Is there other ways that you can support organizations like yours?
Yeah, definitely volunteering. We constantly need, especially people in kind of specialist fields. There's very little. Our patients have very little access to specialty care. There are some county health systems that will provide services, but they are not necessarily low barrier of entry, and so a lot of our patients have trouble even getting into the county health systems. So specialty care is huge. Obviously financial donations and stuff are always helpful, and we appreciate those. But I think the other big one, especially for this group, is around advocacy, especially around housing. So much we're talking about heat-related illness, but so much of the diseases that our patients suffer from are because they are on the street, because they are on alert 24/7 for their safety. Their cortisol levels are extremely high. They do not get sleep. Mental health is affected by that. They develop diabetes, they develop heart disease, all of these conditions that we are treating down the line that could be prevented with housing. And that's just one avenue of how housing helps, right? So we need to advocate for that. We need to increase the availability of housing, how it's built, how people get moved into it, all of those things for sure.
Thank you. And I guess just one other question for Dr. Alcotter is you've mentioned sort of the hierarchy of the agricultural farm workers systems, and it's again sort of for people in the audience, if who particularly are treating rural farm workers or people within the industry, maybe contractors or in construction, do you have any suggestions as how they could tap in? Seeing some of the feedback they're seeing from individual patients into this hierarchy to best kind of affect change. And I know you'd mentioned from the grassroots up is probably one of the best ways, but from the physician standpoint, is there a way that they could have input?
Yes. And quickly, parking lot thing that I forgot to bring up. There's really a lot of overlap in all three of these populations, and we as panelists kind of failed to highlight that. But 2 weeks ago, I was interviewing a 60-year-old unhoused construction worker in Austin. And these things can overlap in ways that create a lot of vulnerabilities. But in terms of tapping into the hierarchies, I think physicians especially could go really far with this, because they're respected and the voice is respected, the knowledge is respected. And so ways to do that are the most efficient ways would be to tap into these different industry associations or trade associations, because they host webinars and stuff like that. A lot of times it kind of depends on who you want to talk to, but we get out the word that way and especially emphasize like rest breaks and shade to those groups of people. But they're often willing to listen to people who work in health departments or in the healthcare system.
Okay. Yeah, no, thank you for that. We're sort of approaching the end of the hour here. There was one comment from Peter Bella. Maybe we'll make this our final questions. Any insights from the excellent panel on insights into consistent and accurate reporting and coroner reports of heat-caused mortality, including deaths in low-income settings? So kind of related to the issues of claims data. But any of y'all would like to comment on that, feel free to.
I don't think I have anything definitive to say, except as a group, and I'm including myself, we are very bad at being accurate in reporting on death certificates. I've yet to meet a physician who really likes the system here in Texas. I hope I'm not stepping on anyone's toes. And unfortunately, and I do a lot of work in the dementia community. I think it's a lot of correlate. We have no idea how many people are dying of dementia because it's not coded correctly. And I have no doubt that this is exactly the same. And getting that to change and really understanding the importance feels like it's something that very much needs to begin with our medical trainees and help them to understand this is not kind of rubber stamping or just filling out a piece of paper, that there really are significant implications for public health, as well as really documenting and doing right by that individual who has died, to make sure that we are really capturing that information correctly.
Right.
I think just to add in maybe 1 second is I think that's exactly right. And most of these deaths in our population and across these groups are unwitnessed, right? And so it becomes very hard. Oftentimes they may have cardiac arrest, right, at the end, and may have cardiac disease that comes up in an autopsy, but really the driving factor for that to happen in that moment was heat. But that's not going to get captured or documented.
Right.
So.
Right. Yeah, absolutely. Yeah, and just another thought, just like with your work with the Unhoused, myself and my husband volunteer and work with free clinics and and then the homeless in homeless shelters. And it's interesting, my husband's a psychiatrist, and so, his work is well used. But the homeless shelters, there's many that won't even use the homeless shelters that are available because they don't want to they don't want to utilize them. They feel better just being out on the streets. And so that's, providing a place that they feel safe or can use, just go in for the day and even, get a shower, get some water, those things. And then also just, I'm thinking about cooling centers that are available and how we have persons with disabilities or unhoused that won't have the transportation ability to get to those places. So there's so many, aspects, in the larger communities. But if we ourselves go and volunteer and see firsthand, it may help us, have that, just, think about documentation, so we can understand the broad spectrum of how this is impacting our communities. And so we can document it and help drive change.
Thank you. Yeah, well, I want to be respectful of everyone's time. We're going to be restarting at 12:15 with Dr. Cantu's discussion. And really appreciate, one, the panelists. What a wonderful set of panelists. I know, the research side of me is sort of thinking of a lot of ideas, really generate a lot of discussion. I think all of us, no matter what your practice setting, can take some of these concepts with you, implement them into your own practice, into your own healthcare systems. It's all kind of bundled together. We're all in the same boat here together. So thank you again for the presentations. Wonderful talk. And
economic loss. It's less often that we get to focus on what heat means to people, again, as they walk through their life in the various ways in which they do that. So what does it mean when you have to restrict your child's activities during the heat of the summer? What does it mean where you have to change your schedule? What are you concerned about? Where do you go? What kind of challenges are you having? Are you worried about your electric bill, cooling, your home? How is it at work? So this is the space that Texas Tales works in. Heat as a lived experience. It's how people understand risk, adapt to it, normalize it, fear it, and ultimately survive it. This is a roadmap for what we'll do today. I'll begin with how Texas Tales came to be, and then we'll move into the ethnographic methodology that guided the research. I'll then come back and share some stories. I'll be focusing on 5 stories this afternoon, and then I'll wrap up with a consideration of why these stories matter for public health and policy. So let's start with how Texas Tales began. It's an effort that very much grew out of advocacy work. In 2023, my research partner, Dr. Marcia Pryor, will be moderating a session right after this one. She and I had become involved in efforts to oppose House Bill 2127, a state law that was enacted in September of that year that essentially blocked local workers' heat protections, including water and rest breaks. So at that point in time, for us, it became not just a fight for labor policy, but it became intrinsic to public health. In a state where temperatures are continuing to rise and workers are already dying from heat, access to water, shade, and rest should not be optional or controversial. Essentially, these are basic protections for human survival. And just for context, Texas has long held the highest worker mortality in the country, and it remains the deadliest state for Latino workers. So through this advocacy work that we had been doing, we were invited to Houston in the September of 2024 for a worker roundtable at a Teamsters union. It was something that was organized by Congresswoman Sylvia Garcia as she sought to bring attention to House Bill 2127. She invited a Washington, D.C. delegation, which included, at that time, interim labor secretary Julie Su. Purpose of the roundtable was to hear directly from workers how heat was affecting their work and their ability to survive in Houston heat. At the roundtable, Next slide, please. At the roundtable, workers described what heat looks like for them. We heard from a multitude of different jobs: warehouse workers, airports, delivery drivers, utility work, construction workers. Many spoke with emotions. Some used translators to get their message across. We heard from, for example, from Claudia. She's a warehouse worker, born in El Salvador. She works in a factory on the outskirts of Houston doing piecemeal work. She described the conditions as quite brutal. There's no air conditioning and very little ventilation in the factory itself. There are fans that occasionally blow, but she described it as being intensely hot with the air. Claudia went on to explain that there were great restrictions in the workers' mobility. They have workstations, they do piecemeal work, and it was greatly frowned upon for them to leave their workstation. She described the inhumanity of that when coworkers were literally passing out feet from where she was working, but she was unable to render aid, nor were her other coworkers, for fear of losing their jobs. Claudia also described how she suffered heat exhaustion, a heat stroke, and a miscarriage, which she attributed to heat. We heard from Anna that day. She's originally from Mexico. She supervises a small team of aircraft cabin cleaners. And she described the intensity by which that work transpires at the Houston airport. Her team is expected to stand on the tarmac waiting for the plane to come in. They stand, as you can imagine, on the asphalt. There's no coverage. There's no canopies put up for them. And as the plane approaches the gate, it blows hot diesel air on them. As soon as the passengers disembark, her and her team climb into the cabin, at which point the air conditioner is turned off, and they quickly, methodically clean the cabin. She described herself watching some of her teammates pass out from the heat and having to be hospitalized. As soon as they complete cleaning one plane, they go back on the tarmac, and then they walk to the next plane. It can be very close or it can be very far away. The luggage, of course, is being carried on a wagon, but in this case, they were walking. One detail that Anna shared really stayed with me. She described these conditions by saying that there were very few resources and very much reticent for anyone to speak up. She said oftentimes they were forced to drink water that was left over from passengers. Next slide. So these stories, I think you skipped, oh, there it is, that's right. These stories stayed with us. Marcia and I both agreed that we could not unhear what we heard that day. As anthropologists, we recognize them to be more than testimony. They were evidence. We also understood the power of stories and the power of storytelling. That insight essentially became the foundation for Texas Tales. Our commitment was and remains to make those realities visible, to witness and document in an empirical form how heat is reshaping human life across Texas. And in a state where human experience often gets flattened into numbers, political discourse, economic loss, that became our work, carving truth from noise. Okay, so let me move on to the ethnographic focus so I can explain some of the methodology that guided the protocol that we put in place. Next slide, please. So as a medical anthropologist, I came to this work trained to look closely at how people experience health, risk, and the institutions that they shuffle through. This photo was taken during the record-breaking heat of 2023 when I was helping collect heat data in Dallas in the UT Southwestern Medical District, which was one of the city's most intense urban heat islands. That photo personifies in a capshell what it's like to do ethnography. Ethnography is more than just qualitative research or empirical documentations. It's a structured way of understanding, in this case, heat experience. It also, and this is a critical point, it also means being present, being there, being in the community often. So, for context, most health data systems, they look at outcomes. Ethnography is the opposite of that spectrum. It helps us understand how these outcomes are produced. Or put in another way, surveillance can tell us what's happening, but ethnography tells us why it's happening. And that matters for heat because human lives record environmental conditions in ways that our data systems don't always do. They either miss it or they dismiss it. So what you'll see is that the stories we've collected help us to understand what communities know, when systems overlook what they know, and how heat can become part of the daily life and what we can do as policymakers, researchers, and clinicians. Okay, very briefly, a little bit about the methodology and the study design. Texas Tales is currently based on 30 ethnographic interviews. These are ongoing, but to date we've collected 30. It's quite rigorous, time-consuming, and extensive. And these are interviews that we've done across the state. Participants come from as you'll see, a wide range of different professions and lived experiences. Many of the interviews that we conducted were quite long and intense, sometimes lasting several hours, which is also very common for ethnographic research. Some involved travel or field work across the state. And in some cases, the people who shared their stories were speaking from experiences of trauma, crisis, and loss. Recruitment was snowball and network-based, which is also the norm in ethnographic work because we're not looking for statistical representation, we're looking for quantitative depth. And then a final point, all of the interviews were conducted with consent. I've changed all of the names in the presentation, and I should emphasize that there was great concern for some people, even greater than others, but it was definitely a factor about their identity being revealed. And this was particularly true when they were talking about work or the institutions that they were engaged in. So some of the demographic information has been changed, but only to protect their identity, but nothing that compromises the integrity of the story. Okay, so with that context in place, let's move on to the stories themselves. I'm going to start with Denise. She's a public health professional at a large urban hospital in Houston. She manages a community health outreach team of approximately 8 to 12 people. It varies depending on their funding and grants. Much of the work that she and her team do depends on being out in the community, at events, working with families, and typically outside. What makes Denise's story so powerful is that she understands clearly what heat risk is. She knows about prevention and she knows what heat can do to the body. But even with that knowledge, awareness is not enough. What you'll see is that she's trying to protect people within systems that offer limited to no support. Denise's story shows us what happens when heat protection falls to the front line. For her, heat changes the calendar in significant ways. It changes where her team can go. It changes how long they can stay. It changes what supplies she needs to keep them safe and what kind of events are even possible. Denise described to us quietly shifting workloads to be in an earlier part of the year because she knew that her staff would be burdened with the heat in Houston. She also described avoiding outdoor activities in August and September when she could. She always asked her partner to provide shade or access to shade if they're going to be outside. And she spends a significant portion of her budget buying things like cooling towels, Gatorade, IV packs, and personal fans just to keep her team safe. And she herself has witnessed her teammates pass out at events. The structure around her has simply not caught up. One of the things that she also does is she quietly tries to place older members of her team in work positions that are not quite as intense for the heat. But she worries. What happens if other team members complain? What happens if they go to HR? What happens if she has to account for this or justify it to her supervisor? And the bottom line is that the grants that she writes for and applies for, the partnership expectations, and even at the hospital with their emergency management system, which doesn't recognize heat, the system continues to treat heat as an inconvenience in the summer rather than something that's affecting their public health workers to the extent that it is for Denise. And that's the disconnect. Heat is reorganizing public health work while the institutions around them continue to ignore it. Next slide, please. Cecilia is a physician in the Dallas area. Most of her patients are on Medicare or Medicaid. She often sees heat through their lens, which is people already struggling with social, financial, and medical vulnerability. Cecilia's understanding of heat, however, is not limited to her patient population. She's also a mom and taking care of elderly parents. So for her, heat is also part of the family dynamic. It's about caregiving and it's about protecting those she loves. Cecilia's story builds on Denise's story, except it does so within the clinic. It shows what happens when physicians recognize heat risk, but medicine and policy have not fully caught up. What Cecilia's story teaches us is that heat is already in the clinic, it's already in the hospital. What stands out in her story is the gap between clinical guidance and lived reality. A clinician, for example, can tell a patient, you need to take breaks, you need to drink more water, you need to avoid heat at this time of the day. But if that patient doesn't have agency through policy or work lift, those guidelines that we are giving them for public health and in medical practice become not actionable. And even inside medicine, Cecilia casts the light on talking about her colleagues. And she says, yes, the physicians I work with are open to heat. Some of them talk about it, but she said it's really not on their radar. And of course, it's not on the radar because it's only been in the very recent past that medical schools have begun to teach and educate students, residents, attendings on issues related to heat and other environmental issues. Most clinicians to date have not been trained to think about heat, especially. And although we're starting to see changes in this arena, it's fair to say that the training is still fledgling in many cases, and it's not consistent across the board. It's hard to get real numbers, but on average, we think that about 50% of US medical schools currently offer courses on environmental health, but the vast majority of them are taught as electives and or in the first year of didactic training. So that's a problem. Again, what we see is that it sits outside of the reality, in this case, of clinical practice. Diane's story moves us from the clinic and into the morgue. She's a forensic photographer in a large urban medical examiner's office, where her job is to document death. You'll notice that I have not put a star on the map to indicate where she lives because she herself was quite fearful of her story being revealed or the setting in which she's speaking from. So I've left it anonymous. Suffice it to say, it's a large morgue in a major city. What makes her story unique and revealing, if you will, is that Diane sees patterns of heat-related death that official systems continue not to document. Her story is also, however, about what becomes visible when heat shows up not only as a cause of death, but when the circumstances surrounding the death itself prevail. So one of the first things that Diane told us in the interview was a story about how she was driving to work last July, early July. And her habit was to listen to NPR. And on this particular day, she heard the news report that the county had finally documented its first official case, heat-related case of the year. And she said it stopped her in her tracks. She actually had quite a sense of humor. She said it stopped her dead in her tracks. But she said it was shocking to her because she knew from being in the morgue that they had seen a lot more deaths from heat than the one that was finally being recorded in July. And what's interesting and important to note about this is the lived experience of Diane. She's not looking at dashboards. She's not looking at death certificates. She's seeing the body, the scene, the circumstances, and the pattern over time. For her, heat leaves evidence on the body and around the body. Sometimes it's visible on the body when she described in great detail how skin will slough off. Sometimes it's visible, she said, where someone is found. All of that is part of the forensic record, what they lacked, or what was happening at the time of their death. And that is evidence too. It may not be showing up in our official account, but it's there, it's part of this lived experience. Diane's story brings us to the fatal end, if you will, of what happens on the heat pathway. For her, heat deaths are not only about temperatures, it's about who has air conditioning, who can afford to use it, who's living outside, and who has support before crisis hits. And literally, she said she would go to work, she would see unhomed people congregating around the county hospital, and she knew inevitably many of them would end up in the morgue, which they did. Her story also shows that heat becomes deadly through social conditions, and this was a theme I heard in the earlier panel. The weather may be the trigger, but the vulnerability is built into the system long before the death itself. And so what Diane does is she points out that heat does not only expose vulnerability, it can also exacerbate existing trends. For example, she has a formula that she uses. She calls it her Texas formula because she says she sees it every summer when she looks at heat. She said drinking plus heat plus guns equals violence. Now remember, Diane knew nothing about the empirical record. We have solid data that now shows when the temperature increases, we see homicides increase, we see domestic violence increase, we see even social media rage and bullying increase with the temperature. She wasn't coming at it from this perspective. Her lived experience is quite literally in the morgue. And this connects us back to Cecilia's story, if you will. Cecilia sees patients trying to manage heat without real protection before it becomes a crisis. Diane sees what happens when that lack of protection becomes fatal. Okay, Annie's story is going to take us out of the clinic in the morgue and into hill country near Fredericksburg a few weeks after the July 4th flooding in Kerrville County. Annie is a rancher and a self-described full-time Texan. She's in her mid-70s. She lives alone on a ranch that has been in her late husband's house for many generations. It's the place she described as feeling most safe and most at home. What stands out in Annie's story is how deeply rooted she is in place. She knows the land, she knows the water, she knows the wildlife, she knows her neighbors, and she knows the climate risk. But for Annie, heat is not separate from drought, wildfires, flooding, water, aging, or isolation. It's all part of the larger landscape she navigates in her daily life. And I heard that theme come out earlier as well. Annie shows us how heat reorganizes her daily life. It's quite intensive. Probably we spend at least 45 minutes or an hour documenting what she does to survive in this climate. Her day is structured around avoidance and preparation. She doesn't go out after 10 a.m. She always has extra water and gas tank in her truck. She uses blackout curtains in her home, and she covers her farm equipment with sail cloth to protect it from the brutal heat. And she said she always has a backup plan to her backup. But this is not just personal caution. It's what daily life looks like when heat, age, and remote rural life merge together, as they so often do. Annie's story, and this is an important point as well, is also about community. She doesn't romanticize the fact that there were true and sometimes contentious political divide within the area she lives, within her community. She described at great length the differences that manifest politically. But on the ranch, survival creates a different kind of relationship. Neighbors may disagree about political issues, but they still check on each other and show up when conditions become dangerous, such as what we saw with the flood. The other thing that Annie's story does is it reminds us that local knowledge is environmental intelligence. She reads the land through experience, the water, the flooding. She told us in great detail, watching how gravel can travel under certain conditions of rain or when the floods came. She knew that land and those trees and those trenches like the back of her hand. Her story is not only about climate risk, it's also rooted in this type of local knowledge, local care, and the way people living closest to the land often have knowledge before official systems do. So, as a context, Diane and Cecilia showed us the gap between lived risk and institutional response. What happens when systems don't recognize it until it becomes either a crisis in a healthcare setting or in death. Annie's story widens that lens for us because it shows what happens when local knowledge is there, it's present, but the systems either dismiss it or decide not to treat it as evidence. When Marcia and I were there, it was again right after the floods. So there was lots of discussion about who caused the flood, why wasn't there notification, and why did this have to happen? And there was dissent in terms of what that looked like. ProPublica did an investigative article that came out shortly after. And what they found was that the local knowledge about the flooding, about nighttime flooding, and how quickly the floods rose was known in the community. In fact, it had been carefully, meticulously documented through oral histories 10 years earlier. Remember, these are generations of people living along the Guadalupe River. They know that river, as does Annie know her land. Unfortunately, it was never included in any of the state reports because it wasn't considered data. We saw a lot of contention while we were there. Annie insisted that they had received money from the IRA funding that the local police used for bonuses, and rather than investigate or rather than invest in a notification system. And so, just as a point of clarification, as an anthropologist, we're documenting what people say as opposed to questioning or challenging what they're saying. But it's critical to understand this connection between lived experience and local knowledge and the disconnect with the system. And as a quick anecdote, I'll share that a couple of weeks ago, I was in San Antonio for the South Central Climate Resilience Forum. And they brought together a panel of experts to talk about the Kerrville flood, what had happened, and what they were doing to prepare so that it wouldn't happen again. I think they had 5 experts, meteorologists, climate scientists, city planners. Not one person on that panel had any expertise in lived experience or local knowledge. Again, it was dismissed. So that's quite disconcerting. Bottom line is that Annie's story helps us to know that lived experiences is not outside the evidence base. It's integral to the evidence base. That local knowledge is not separate from data. It's data. We're just not treating it as such. The next story I'd like to share is from Anaya. Her story brings us back to Dallas, but from a very different vantage point. She's a Spanish interpreter that works across several institutions, hospitals, courts, and CPS. That means she sees immigrant families, mostly Spanish-speaking immigrant families, moving through multiple systems and often at moments of crisis, fear, uncertainty, and injury. Anaya's story also came to us somewhat differently than the others. We didn't recruit her. She knew about the project that we were doing, so she approached us. She was alarmed at what she was seeing, and she wanted to tell her story so that it could be documented and she could bear witness anonymously. So that's what we did. It was probably one of the longest and most intense interviews that we've done. What makes Anaya's story powerful, as you'll see, is that she's not just, again, speaking from one site or one role. She's seeing patterns across systems and across people. She describes it as a type of quote unquote perfect triangulation because her work gives her a view of how health, law, poverty, language access, in this case, collide in immigrant life. Again, another theme from earlier when we talked about the intricacies and the multiplicity of these relationships. Anaya helps us also to see heat vulnerability not as a standalone issue, which again is critical, but as something that's layered into already fragile systems of survival. Anaya began her story and spent quite a bit of time talking about fear. As a Spanish interpreter, she sees what happens when people have to navigate systems that they don't fully trust. She described fear not only as an emotion, but as a healthcare barrier. It shapes whether people ask for an interpreter at the hospital, whether they believe what the provider is telling them, and whether they go to the ER in the first place. And this is why the phrase that she used several times, which is fear is now on steroids, is relevant. For many immigrant families, fear has always been present, but now it's amplified. And Anaya told us from economic pressures, ICE, misinformation, and the stress of holding together households under these geopolitical conditions. Anaya helps us to see that access is not only about whether services exist, it's also about whether people feel safe enough to use them. And that matters for heat because when people delay care, avoid institutions, or feel that they can't ask for help, heat risks become harder to see and harder to manage. Anaya also showed us another message, how heat public health messaging are failing. Public health guidance often assumes that people are ready to receive that message, but fear, language, trust, lack of agency all converge when messages can't be heard or can't be acted upon. We saw that with Cecilia's story. For the immigrant families that she works with, it's often part of daily life. People might pack a lunch and pack water because that's all that they can do. That's their reality. They don't even have the questions to be able to challenge what they're dealing with. We saw a similar public health messaging, albeit from a different context, for many of our other interviews that we conducted. This one is from Jan. She's a mother. She has 2 high school boys. She owns a small business in the suburbs, and she's very knowledgeable about heat in athletics. She knows that her boys are at risk, and she knows that people die from the heat. So when we continued the conversation, it became clear, she said that in thinking further about what was happening, she realized that she didn't ask questions of the coach because she didn't know what questions to ask. And I think this is a really important point. If you look at the public health messaging that we have, it tends to be very generic and very ad hoc. We tell people things that are not matching their reality or that physicians are not able to share with patients because they know that they can't act on them in actionable ways. The notion of stay hydrated, avoid the heat at this time period, those are luxury items for many people. And the other thing that I'll point out is some of the messaging that we had. I saw it a couple of weeks ago when they had the heat wave along the Northeast coast. They were sending public health messaging out that said something to the effect of, it's going to be super hot. We've got a heat wave. Make sure you avoid caffeine. That's not going to cut it. And we do the same thing with air quality in Texas. Most of you have lived in Texas, you know, when the air quality gets bad, it's always bad. We start getting alerts to avoid the car drive-through lane. Is that an effective public health message? Maybe not. But together, what Anaya and Jan show us is that heat accumulation cannot just be limited to delivering instructions. It has to begin with people's lived experiences, what they know, what they fear, what they can control, what they can't control, and what they're able to ask. Public health communication fails if it assumes that everyone already shares the same time frame for risk. And one more quick point, because it's something that we don't talk about, but it showed up in the data, is that frontline workers, many of whom are negotiating this system without the support that they need for meaningful change, are on the front line for trauma. We saw this specifically with Anaya. She said she's perpetually pissed. She's no longer the translator she was. We saw it with Diane, who struggles every summer, quite literally physically. So heat, takeaways that heat doesn't just affect people who are directly exposed, it's also taking a toll on our frontline workers. Okay, the last section. Together, what these stories show us is that heat risk is holistic, it's relational. I'm not, go back to the other slide, please, so I can set it up. The stories that I've just shared with you show several things. It shows that we're already dealing with risk. It's not being supported. Lived experiences are very limited, if at all, in terms of how they're converging to be in our public health screening and messaging. And that's why lived experiences matter. In this final section, what I want to do is step back from the individual stories and ask what they show us collectively. What makes stories visible? What systems can continue to miss? And why lived experience has to be part of how we understand and ultimately respond to heat. Okay, next slide, please. This is an image of the 1900 Storm Memorial Flood Marker in Galveston. It marks how high the water was during the major storms of 1900 and Hurricane Ike. But what I'm going to suggest is it's more than a memorial. It's a form of environmental memory. We've seen the same phenomenon in Japan along the coastline with the tsunami stones. Communities such as Galveston and in Japan, they use these markers to warn future generations where not to build, what the flood was like. This is data. And so this knowledge is not just anecdotal, even though we dismiss it, it's evidence. The question really becomes is whether we're willing to treat these in the way that they can become meaningfully integrated into the clinical and public health work that we do. Next slide. If stories help us see what numbers alone can't, they also raise a harder question. What are we choosing to count? We have built sophisticated systems to track breaches in planetary boundaries. We monitor these thresholds with extraordinary scientific precision, but we rarely apply that same rigor to the social conditions that we are also breaching. When people cannot cool their home, safely go home, ask for help, trust care in the system, protect their children, those are breaches too. They may not appear on the diagram, but they are real, and the stories help make them viable. And that brings me to the human factor. If stories show us what systems overlook or dismiss, they also show us what happens when people are reduced to costs, categories, or data points. When systems only count economic impact, human lives become easier to discount. And we're seeing this play out right now in policy, with the value of human life no longer being stripped from the environmental equation. A missed warning, a delayed ER visit, an unsafe job site, a home without cooling. These are not just outcomes. These are human lives. Stories matter because they restore what metrics cannot hold: consequence, context, and human worth. And that's the larger argument behind this research. If we want heat response to protect people, we have got to build systems that still see people as people. And I'll close with a quick postscript. As you recall, Annie's story reminds us that communities are never as simple as they might appear on a political party or labels or maps. She describes a place where there is contention, but survival is the key for them to be able to coexist. We're seeing the same phenomenon play out right now in Big Bend, where opposition to the wall is not falling into neat political party lines. It's being organized along place, livelihood, memory, and belonging. And that's what ethnography, and that's what stories help us to understand. Quantitative measures can tell us how a county votes, boundary runs, or what the political opinion breaks down to. But the stories are how people actually live through these dynamics and the complexities that's ultimately human life. Heat protection, I offer, cannot be achieved through labels or maps alone, or even clinical evidence. It depends on trust, relationships, and the realities people are forced to negotiate and navigate on a daily basis. And that's why stories are not supplemental. They are how public health learns to see. And then I'll just quickly acknowledge, big shout out to deepest gratitude to those who shared their stories with us. In many cases, you could see it was painful, but they wanted documentation. And then a wholehearted appreciation to my amazing thought partner, Dr. Marcia Pryor. We've been working together for many, many years, and she's amazing. And then a quick shout out to our intern, Divya, who is finishing up her degree in public health, but has jumped full force into ethnography. And then my last gratitude is to Texas PSR for finding the space to include this in the panel. Thank you very much.
Thank you, Becky. Good afternoon, everyone, and welcome to our panel on innovative strategies from the nonprofit sector addressing heat deaths. Before we get started, I just want to mention that we will hold off on questions until the end of both of our presentations, and you can put in questions in the chat or verbally ask them after our presenters have completed their presentations. Our speakers today are both advocates for building awareness of heat deaths. Mr. Greg Harmon is an award-winning journalist and editor known for his incisive reporting on environmental justice, public health, and climate impacts across Texas. As the founder and managing editor of Deceleration, he brings a sharp, human-centered lens to the stories shaping our environmental future. Dr. Amit Dominic is the founder and president of Texas Prisons Community Advocates, where she leads efforts to expose the inhumane conditions in our state's prison system. She has been relentless in advocating against extreme heat in Texas prisons, highlighting its devastating impact on the health of incarcerated people. First, we'll hear from Mr. Harmon. Greg?
Yes, thank you. Thank you, Marcia. And thank you for having me. My name is Greg Harmon. I'm the founder, managing editor at Deceleration. And I wanted to talk something that's happening right here in our community, what motivated us to move into the coverage that we're doing here. And we can start the slide. Is that yeah, thank you. And so we've been looking at the impact of extreme heat on our neighbors and the systems that are essentially failing to protect them. We are a bioregional journal of environmental justice entering our 10th year. I think we're maybe one slide ahead. I'm not sure. Okay. Yeah, no, you're right. We're entering our 10th year. We're based in San Antonio and serve the greater Central and South Texas region. And we've been thinking about our coverage area, not just in terms of political boundaries, but along watersheds and kind of shared stakes in that way. That means our coverage begins with the Sacred Springs to the north of up by the San Marcos and flows down following those waters to Corpus Christi, the San Antonio Bay, and also extends culturally along the borderlands more generally. We connect frontline community stories to global movements and emerging thought in the field of climate justice. That mission is what brought us into this kind of sustained reporting project on extreme heat. And yeah, this is my little bio page. So my background, I go back to the late 1990s, writing in Texas with daily papers, alternative weeklies, freelance work, later that came to include The Guardian, Indian Country Today, and the Texas Observer. I wrote my first story about forced climate migration for The Guardian in 2016. And I spent 5 years then I operate on the spectrum, moving from kind of like daily beat reporting into like advocacy journalism, and eventually became an organizer myself, working to shut down coal plants or get commitments to shut down coal plants in San Antonio. And it was through that period that Deceleration kind of grew, where it seeded this, slowly on the one side and built into what now has very much been a labor of love. Excuse me. And we can advanced. Yes. So our focused coverage on heat and the human cost really took shape after actually Winter Storm Uri in 2021 and what came soon after. What began as coverage sort of like cold weather disaster revealed something different quickly, and that most people that exposed to climate extremes are the same people that the system has failed. And so when they die, oftentimes we found that their deaths go uncounted, and particularly kind of like we've talked and heard from guests on this panel, on this conference today, unrecognized or unremarked as, the appropriate attribution for cause. Over the past several years, we mentioned, Albert Garcia here, who first lost their feet and part of one leg during Winter Storm Uri, and would be killed by extreme heat the following in the summer of 2023. Jessica Witzel reinforced this idea that we kind of gained this insight into this vast insight and undercounting of heat-related deaths. We began to look at gentrification and development patterns in the city of San Antonio, and found even like we talked about the variation in urban, of heat island and urban centers. 10 degrees is pretty common. We located one site that was 21 degrees higher, looking at heat index than what the official temperature was on that day. And so this is sort of like just intended to give you a kind of like map of the kind of work that we do. And I'll put some links in the chat when I conclude of, if you want to go to some of these stories directly, go forward. His name is Albert. So 2022, my co-editor and partner, Marisol Cortez, essentially this came out of just, life in San Antonio, in our neighborhood. We were crossing the highway and we noticed someone lying in the mud on a rare wet day in San Antonio, just this kind of like a huddled, person there beside the highway. And we stopped, and Marisol wanted to go out and visit with them, and ended up kind of like propping an umbrella. They didn't want anything. They didn't want to be moved or help moving out of the rain. And so we just propped this umbrella over them, and we weren't able to respond much that day. And that was our first encounter with Albert Garcia. And I mentioned, the loss of their feet, and their campmate described it in graphic detail. We did later on some video after their passing about that experience. But we started a sort of a reporting actually didn't start as a reporting project. So for Marisol, it began just, how are we going to get Albert housed, right? And she began, there's a small team of folks that kind of came together with our local district council field office, some city, staff, and community mutual aid workers. Like we should give credit to Yanaguana Herbolarios that do street medicine in San Antonio. And so this project, it took over a year, and what we learned, a lot through that process, which became a reporting project, because of the frustrations that we experienced, were all these interlocking vulnerabilities that leave people behind. Ultimately, Albert did get into a group house. He was happy, was clean, from a drug addiction, and for over a year. But then they returned to the streets in the summer of 23. After making an outcry of abuse in that facility, we immediately reached out to all of our old partners and others to find, to get them off. We knew as soon as they came back to the street, the drugs would be an issue, the heat would be an issue, and it proved to be the case. Under the highway in 23, at one point, what I measured to be 100 and up to 115, 116 degrees. When the official temperature was 105, Albert passed away in the middle of the night. And the medical examiner in this case listed the cause of death as a drug overdose. Albert had been injecting drugs that morning, but typically a drug overdose is something that you'll see in this case within 10, 20 minutes tops. This is 12 hours later. Their campmate also described how Albert had been passing out daily multiple times just in the dirt under the highway, and that he himself had been fallen down just going to the grocery store to get water and supplies, and been treated by EMS at least twice for heat stress. So that was, that was the beginning of what became kind of like a multi-year project. We can advance to the next slide. The following summer, we received word that a childhood friend of Marisol's, Jessica Witzel, was in crisis and living unhoused in the Five Points neighborhood or area of San Antonio. And we were, already preparing resources to try to get, to her and to be helpful with the family. And literally within like a couple of days, we received news that she had died on the sidewalk in the middle of the day. And again, in this case, the medical examiner recorded the cause of death as a drug overdose. And when we got, again, like with Albert's case, we got the, months later, we get the autopsy, we're reviewing that, and we're sharing that with, medical professionals for their assessment. And Rose, we've talked with Rose through the years on this and others. And this was essentially a or near subclinical level of methamphetamine. I should say in the days before Jessica's death, she'd essentially been hounded around the neighborhood. One neighbor where she was trying to cool herself with a garden hose called the police because she was using their hose, right? And they did take her body temperature shortly after her death, and it was 126 degrees. And this is one that we heard from others that, was the highest that they've ever seen in a case like this, that it was a kind of a poster case for a heat-related death. The family was pushed back strongly on this idea of a drug overdose. And we heard earlier also about, how certain medications can lower our tolerance for heat, but they can also leave residue. In this case, there's certain bipolar medications that we've learned that can present, and leave a trace of methamphetamine in the blood. And that's what we think was going on here. But in this case, the medical examiner, we'd been involved in a 2-year campaign by now to try to get heat tracking in San Antonio and Bexar County. And the medical examiner, aware of that criticism, had left a note in the autopsy saying, heat was certainly present that day, but without being able to personally witness the death, that she refused to even include heat as a contributing cause of death. So this idea of the vast undercount, we'll advance to the next slide. Thank you, Marcia. Is one that we've really kind of dug into. For OSHA, for instance, we know that they've in some of their communications have used the term vast undercount in their communications about, while heat is the #1 weather-related killer in the United States, we really have very poor idea of how many people are losing their lives to exposure. Very recently, we spoke with a climate scientist at Texas A&M who published a peer-reviewed research running 3 separate models for calculating heat deaths in the state of Texas. And their conclusion was that the numbers being captured here are roughly 1 in 6 of what they would expect to see. In 2023 alone, we requested the existing data from the state of Texas. This is the year that Albert died. We found nearly 600 heat deaths, either as a primary or secondary cause of death. And if those models are accurate, then 2023, we may have lost over 3,500, as many as 3,600 people to extreme heat. And also, as an interesting side note, that heat in their modeling, they found that the bulk of the heat was actually happening at what we might consider a moderate, or an average summer in like the lower 90s and upper 80s even, that while there are also these spikes, of deaths that occur with the extreme temperatures. We reached out to the CEO of Sam Ministries, and just anecdotally, they told us that they expected dozens. Every year they have a service, I should say, at the end of the year to honor those who are living unhoused that lost their lives that year. And they're just kind of anecdotally reflecting on the year, said that they expected that dozens of those deaths were likely related to the heat. And obviously, and we're going to hear about the incarcerated populations here as well. In Texas, we think about those most vulnerable being unhoused workers, both, outdoor workers, but frankly, warehouse workers, indoor workers too, sometimes, seniors and young children, and those taking certain psychiatric medications have higher vulnerability. Slide 8, please. So one of the things I started to do, it's up here on the shelf. I'm not going to grab it, but kind of like I saw Bill Barker's on this call in San Antonio, and none of this is going to be new because I've shared a lot of this with Bill, and we share a lot. And I started carrying a temperature gauge, temperature, heat, and humidity gauge with me throughout the summer to better understand and better report what people are actually experiencing. I think this is critical, really, for folks to have an awareness that when they turn on the TV and they see 105, they think, "Oh, that's hot. I should take care." That it might be much, much hotter than that. And so I think the communications is something that we've stepped into as well through at Deceleration. I talked about, recording the camp at 116 degrees. I recorded it, the heat and humidity, that heat wet bulb temperature at 119 at a downtown construction site. That was an active construction site that afternoon, though they did appear to be offering shade and water. And the gap really here in this is really about deciding, in the title of this presentation, deciding who lives and who dies, how we communicate, how we track, and how we protect or fail to protect people. The World Health Organization recommends that older and vulnerable populations have several hours each day in a space cooled to the 70s to allow their core systems and core temperature to recover. And I rarely see that kind of information shared in Texas. Next slide, please. So we've responded and talked about responding in multiple ways. We've built tools. We were doing mapping. I think even before the city of San Antonio, we were mapping, for instance, energy security, a lack of energy security, how much people were paying on their bills compared to, income. We were mapping heat islands and intersections, which is something I will say the city's done a really good job in the last few years on. I begin to rely more on their analysis and mapping of those issues. We produced let's see, in addition to those, so some of those were shared, like the local utility was using our maps on energy vulnerability in their outreach, or energy burden rather. And we issued, and we stepped kind of across, this threshold of impartial reporters to launch a petition, because I will say the Albert Garcia stories, zero area media stepped into that story with us. We're a grassroots project that and maybe we're easy to dismiss because of a kind of a marginal. We exist in this kind of on the margins, which is where kind of new models kind of find their soil to grow and thrive within. And because there was that lack of uptake in that case, we kind of stepped over and we began a campaign, and we held a heat emergency forum with Dr. Adelita Cantu and Rose Jones joining us, and made other efforts to reach out with the city and community. Let's see, and next slide. We have seen some progress locally. In April of 25, the San Antonio's Governance Committee overrode a staff recommendation of no action to take action on tracking heat deaths in San Antonio and Bexar County, and that was a big victory for us. We got it into city discussion with the CCR staff, city manager's office and Metro Health. Their position was, we know what causes this. It's really difficult to track heat deaths. Therefore, let's reserve our resources to responding to the crisis, to, tree canopy or lowering the temperatures. And the mayor and several council members said, no, this is important. We're going to find a way to do it. We're in the middle right now of seeing some of those recommendations roll back into potential policy. And I'm not sure, frankly, that when it comes to heat tracking, that there's actually a proposal to do things differently. What we heard come back this last week was that they're going to rely on state data. They're going to reinsert into their dashboard, not just heat illness and heat stroke, but they're going to reinstate mortality data, which they had up until we began our reporting and pointed out or highlighted for community that those little asterisks and the NA that they had in those categories didn't represent it wasn't applicable, just that it wasn't available data. And that's going to remain the case, even if they reinsert that into the dashboard. So we really need something a little more directed towards what's going on. And next slide. I guess maybe I'm one behind. Is there one more? I will say that Albert Garcia died of the heat. We're convinced. Testimony, I think, proves that out, and everything we've been able to learn about their life proves that out. Jessica Witzel is the same. In both cases, they're recorded as drug overdoses, and the gap of that is essentially it's more than clerical error. It's a decision that's been made about how we're going to bear witness. Deceleration exists. We're not just a heat journal. We do write a lot about this, but we're also writing about ICE and detention and human rights and democracy, anti-fascism. We're writing about water security, data centers, energy, public health, air quality, all of the rest. And I'll stop there to try to reserve more time to conversation. And I'll put some links into the chat. But I just really appreciate this whole forum so far has been really inspiring and really necessary. So thank you again.
Thank you, Greg. That was very informative, also very disturbing. We appreciate you sharing this information. Our next speaker is Dr. Amit Dominic, who's going to speak to us about something equally as disturbing, and that's the inhumane conditions in our Texas prison system. Go ahead, Dr. Amit.
Good afternoon, everyone. We've had such a stellar event so far. It's been incredibly interesting listening to all the conversation that has preceded me, and I'm looking forward to the remaining sections. I'm going to talk a bit about innovative strategies for addressing heat, not just heat deaths, but heat overall within the Texas prisons. Let's go to slide number 3 and then go back to number 2. One more. Oh, no, sorry. I guess we have a different version. It should be the slide that talks about the organization and what we do. Yeah, it looks like you went way far. Should be slide number 3. There we go. Yeah, that's where we want to be. So a little bit about our work. I'm the founder and president of Texas Prisons Community Advocates, and I've been working on the heat within the Texas prisons for about 10 years now, with the organization actually being founded in 2021, and started doing political work to the point where we had got the first bills filed on the topic in 2019. So we serve incarcerated people, their families, and their communities, impacted incarcerated individuals as well. So we have a two-tier structure of our Texas campaign and national campaign and coalition. Just to give you an idea of the numbers behind the Texas prisons, because oftentimes when I talk about the fact that there's no AC in the majority of the Texas prisons, it's really shocking, especially considering the fact that we have the highest rates of incarceration throughout the United States. So currently we have over 142,000 people incarcerated within TDCJ. That number varies daily. We average pre-COVID between 145 and 155, and then there was a major drop, and now we're back up past 142 and rapidly climbing. There's over 90,000 individuals right now within the Texas prisons that do not have adequate air conditioning within their prison facilities. There's 104 prisons throughout the state, or 104 facilities within TDCJ's portfolio throughout the states, and only about 36 have full air conditioning. And it's important to understand the differences within the prison facilities as we have full, which means there's air conditioning throughout the facility. We have partial, which means that there's probably only air conditioning in the places like where the guards are at, where the warden is at, maybe in the chapel where visitors come, but not necessarily where individuals are sleeping. And we had over 10,000 heat grievances filed just in between 24 and 25. What is a heat grievance? You can go back a slide, please. A heat grievance is a way to communicate to the system that, to the one with the quotes, that the individuals are grieving any type of conditions. That should be it. There we go. So these are some of the things that individuals who are incarcerated would report regarding the heat conditions. Now, this information comes from a report that we did with Dr. Carly Purdom at A&M University, where we had sent in surveys to incarcerated individuals and asked them about the conditions related to heat. And they gave us a series of responses. We also looked at the mitigating factors that TDCJ uses, or mitigating protocol more appropriately. And a lot of the protocol measures are things that we've heard earlier today. However, because of the uniqueness of the situation, they're extremely ineffective within the prisons, particularly because starting point would be that TDCJ is constantly understaffed, which means that doing things like bringing a group of 80 people to a shower because they've requested to take a cool shower is logistically impossible to accomplish. Also giving them cold water all throughout the day, logistically impossible. Facilitating respite areas where they can cool off for a period of time. Their respite areas are only so big. Maybe they're a chapel, maybe they're a warden's office. That's only going to fit a certain percentage of people. So those mitigating factors are not effective. And then we all know that the most effective way to deal with heat is through air conditioning. So I just want to highlight some of the comments that real people are experiencing during this situation. I have no family to help me. I'm at the hobby unit with no air conditioning. I can't eat. I can't gain weight. I suffer from the heat. I get dizzy. I get headaches. I'm weak. I have diarrhea too with leg cramps. I've passed out several times, and they don't allow respite. So, prime example of where policy does not equal practice, where the agency would state that individuals could receive respite, and we don't see that actually happening. In terms of the heat-related deaths, we strongly suspect that these deaths are undercounted. You can go to the next slide, please. For a variety of reasons, some of which that we heard earlier today, but the number one reason being that TDCJ is not required to take core body temperature at the time of death. These individuals, just to give you a uniqueness about their circumstances, they have no choices. So no escape. They can't go out into the cool air. That oftentimes rec is even more dismal during hot months than during the regular months. They can't buy a fan without permission. Those costs are usually the burden of their family members. It costs about $23 for a personal fan, and all that's doing is circulating that air around the prison. They can't refuse to work. Working is also an issue. Each incarcerated individual is required to work unless they have restrictions that are signed off by a medical provider. So these individuals can't say no to that work, although TDCJ has adopted some of the OSHA standards, and they're still not being shown to be terribly effective. They're locked in a building with no natural ventilation, so the ventilation is also a problem within the prisons. We're talking about brick, concrete, steel, the same materials that you would utilize to make an oven. Temperatures are oftentimes over 90 degrees and persistent at midnight, and they're not allowed to take a day off during the heat. I'm going to share one story from a formerly incarcerated individual that I think really sums up their experience. This individual was sleeping in a cell with no windows, and about 2-3 o'clock in the morning, she starts to dream about rain for some reason. And while she's dreaming about rain, she wakes up, and she wakes up to a drop of water on her face. She looks around, there's no windows, the toilet hasn't overflowed. She's trying to figure out where the water is coming from. She looks up, and it's her bunkmate's hand that's dripping down sweat upon her. So these individuals are not cooling off during the night, and even being still, they're still experiencing extreme temperatures. So extreme that when we look at the documented heat deaths, and TDCJ is very resistant to actually stating that some of these heat-related that these deaths are heat related. We're looking at internal body temperatures anywhere between 103 and I believe 109. So that's how hot these individuals were internally when they passed away. There's also a medication crisis. Over 30,678 are individuals who are incarcerated are prescribed psychotropics within TDCJ. That's a 2017 statistic, and those statistics have been changing. They have moved towards medications that are not psychotropics as much as possible, or alternative medications. About over 27,000 on blood pressure medications that worsen during the heat. A large population of individuals with diabetes, individuals taking diuretics, beta blockers, and about 56% of the incarcerated people are on medications that worsen heat vulnerability. And that was according to the report we had done several years ago. And so those numbers are constantly in flux. Many medications cannot be safely stored in extreme heat, so the medications are susceptible to degradation. Institutional indifferences, about 60% of the individual surveys said that wellness checks weren't happening. So, for example, what is a wellness check? Your family member may call down to the prison and say, I haven't heard from my loved one. Can you do a wellness check? My experience as an advocate is oftentimes that those family members and friends have been hung up on, or the medical check didn't happen. We had one volunteer, Jason Wilson, who passed away in 2024. This individual was asking for respite, asking for cool water. A volunteer with our organization had checked on this individual, called down for a wellness check, was told he was fine, found out later, several days later, that he had died over 4 days prior to her calling. And she was told that this individual was doing okay. The heat score system covers only about 12 to approximately 12,000 individuals. And the heat scoring system, a little explanation on that, it is an algorithm. And based on this algorithm, you get points in terms of your medical condition that would lead to you being placed in a cool bed. A cool bed is not a cool mattress. It is simply an area within the prison that actually has air conditioning. I can tell you from the recent lawsuit we just experienced and listening to the UTMB expert who spoke on the algorithm, was part of developing the algorithm, her comments were things such as, I have no evidence, and I was not taught in medical school that diseases such as diabetes have any relationship to heat-related illness or death. We found that to be shocking, just that statement alone. Incarcerated people are coerced to abandon heat restrictions. So those who do meet the algorithm, they can sign a waiver to not be placed in a cool bed area. And why would they do that? They do that because oftentimes they lose their privileges by being forced to be in those specific areas. As TDCJ retrofits solitary confinement areas to cool bed areas, oftentimes visitation, classes, rehabilitation aspects are lost in that transition. Body temperature is routinely not taken at the time of death, and TDCJ has reported 0 heat deaths in 2025, with 5 OG investigations still open. You can go to the next slide. So just to break that down a little bit, they're saying that they're reporting to the legislators that there were not heat deaths in 2025. However, in our most recent court hearings, we found that there were several deaths that weren't reported to the legislators. And a few quotes from the voices of the family members as well. So another forgotten population are the family members who are suffering alongside of their incarcerated loved ones. And I think we're on the wrong slide here, but we'll keep going here. Yeah, that's where we were supposed to be. Let's see. Yeah, that's definitely where we're supposed to be. I'm trying to, instead of putting on my glasses, switch my screen so I can see it a much larger slideshow. So thinking creatively about how we can change these circumstances. There are several things that clinicians can do. They can advocate for heat-safe medications. They can push UTMB and TDCJ to review medications. They can support heat sensitivity screenings at intake, and they can call for mandatory body and core temperature at the time of expiration. System-level advocacy actions that can also be done, and some of which have been already started, is you can sign on to our action letters, our petitions, reaching out to your political members, letting them know that you want to have air conditioning in the prisons, and offering your expertise as to why air conditioning is the best answer for stopping these unnecessary deaths. Provide expert declarations for testimony. We're finding that this heat is not just a problem within Texas. We're seeing it throughout the United States, and therefore the call for expert testimony is actually ramping up. Partnering with TPCA to design heat health research. We do quite a bit of research at TPCA, and we're also always interested in individuals who can help us out with that. Doing things as small as reviewing medical records is another option. Advocate for independent health monitoring within TDCJ and connect your hospital or medical school to TPCA's research network. Keeping in mind that about 95% of the individuals who are incarcerated will be returning back into society. Next slide. So, family members. I was saying earlier about the family members who are also suffering with their loved ones who are incarcerated. From experience, a lot of these family members become volunteers with TPCA. And I have, for example, an individual who has her alarm set for 3 o'clock every day to check what the temperatures are where her loved one is incarcerated. Family members have tested it out by going into their car with 90-degree plus weather, or locking themselves in their bathroom just so they can experience what their loved ones are experiencing to get an idea of what's going on. Then there's also the trauma of just not knowing if your loved one is going to live that summer, whether your loved one is going to take their own life or the heat will kill them outright, are some of the things that they're constantly worrying about, as you can see from some of these comments. Next slide. Also, what we notice is suicide rates increase during the hotter months, which I think is similar to what we see in the free world. About 60% of our participants wellness checks had not been conducted. 43% had health crisis disregarded. 40% had official heat restrictions not routinely enforced. And 56% were on medications that worsen heat vulnerability. Suicide attempts nearly tripled 2009 to 2019, peaking in the months of July and August. So heat is also related to increased violence, use of force incidents, and homicide within the Texas prisons. Next slide, please. What TPCA does, we do a number of things: research, advocacy, litigation, community surveys for incarcerated people and their loved ones, family member engagement. You see in the background our mock cell, and that was at the Capitol Last time I was at 2023, which allows people to enter into that mock cell and feel what it's like to be in those extreme temperatures. We all know what it's like to be hot in Texas. We don't know what it's like when that door is closed behind us and we're trapped and we might be sharing a cell and a toilet sink combo within that cell. We do legislative testimony and appropriations advocacy. We have our national coalition, which I talked about previously, which includes researchers, physicians, and civil rights organizations. Next slide. I think I think I have like 2 minutes left. Yeah. How you can get involved with TPCA, you can document or how you can get involved in general is you can document and speak. So recognize and document heat-related illnesses in patients who are incarcerated, provide expert testimony for cases, maybe write opt-ed, speak to your legislators, and support TPCA's coalition partners, testify at legislative hearings, and partner with TPCA on our co-authored research, and connect patients and families to TPCA and join the coalition. So those are just a few things that individuals can do. And I think I probably have 1 minute left that I can yield to questions.
Thank you very much, Amit. Both of those panelists provided us with just wonderful testimonies, very powerful, and they demonstrate how far we need to go in supporting and helping our vulnerable communities. We do, if you have questions, please don't hesitate to, you can verbally state them or put them in the chat. We do have one question from Mona. How was the data manipulated so that our state reps would think 0 deaths under reporting? Apologies, didn't catch this portion. Do either one of you want to tackle that question, or both of you comment on, how is it that we don't have good figures on the deaths that are occurring from heat?
Well, I can take that to TDCJ. They have a vested interest, essentially, in hiding those heat deaths, so they are not likely to report them. Also, for the report that they have to give to the legislators, it's in December of each year. So if they have a backlog of individuals who haven't been autopsied yet, those numbers don't make it into the reports that are given to the legislators at the end of the year. And then they furthermore don't indicate that they have a backlog of individuals who are yet still under investigation.
Yeah, and I think in terms of the city of San Antonio, I shared in the chat kind of an anecdotal from a plumber who was working at our house one time, saying local leaders like our quote unquote chamber of commerce weather, meaning, they don't want to disturb would-be tourists with, oh my God, 17 people died last month from the heat in San Antonio, honey. I don't think maybe Six Flags isn't a good idea. But I mean, and it wasn't just a plumber, right? One of our county commissioners in a meeting when they began to have some public conversation about this because of community pressure, one of our county commissioners said, we as elected leaders and economic leaders, what have you, we're not supposed to talk about this.
Okay, thank you. Does anyone else have any questions? Does anybody want to verbally shout one out?
Can I piggyback just a little bit on what Greg mentioned? Our two populations are very similar when dealing with the legislators, and that the legislators don't want to hear about this. So, for example, even being on a corrections committee or a criminal justice committee can be seen sometimes as legislative retaliation. So they don't want the reports out there. They're not interested in it, and they're throwing away people, basically.
Mm.
Representative Canales made a statement back in 2020, I think it was 2019. He said, Texas doesn't have a money problem, they have a give a damn problem.
Oh, that's a very pertinent quote, isn't it?
Mm-hmm.
All right. Well, we have a question for either one of you or both of you. And it kind of piggybacks on this previous question. What is it going to take in Texas to change the conversation around protecting these populations from heat death and severe injury?
I think the answer is always the same: organized people against organized money.
Good.
Yeah, I agree with that. But the root of organizing the people is oftentimes presenting these individuals as human. So it's that human connection, that empathetic connection, that compassionate connection that's missing. My grandmother always said, you never know where someone's been until you walk a mile in their shoes. And one of the things that we do with the mock sales is we offer that opportunity to walk a mile in someone else's shoes. So I think we can do a lot of this through education, right? And that's a key part of making the change.
Yeah, and a quick maybe follow on to that. I was at a conference very recently of resilience professionals from a 5-state area, and I asked in one session about the Hill Country flooding about do any of the individuals who are doing this disaster response and preparation work also feel compelled to it's kind of perpetual job security to be in disaster work these days, and that's because of the world that we're building, and that's fossil fuels and eradicating forests and natural areas. So, and I think all of us in institutional spaces have to be willing to take a little bit, more risk in our own lives, because there's people out here on the street that they're bearing all of the risk. And so we really are looking for folks in these settings that it's not your job title, and there is ways that they'll clap back at you. But if you don't also find ways, maybe, preserve your job, but also get the message out that we're building this weather, we're creating these conditions, and we all have an obligation to kind of like be uncomfortable making things better.
Okay, thank you, Greg. Thank you, Ali. Was there any particular incident or event that prompted either one of you to enter this work, this mission, that would be very revealing?
I guess I'll start with that one. My ex-husband became incarcerated in 2015. And through that, I started talking to family members. I started talking to incarcerated individuals. I personally would try and get to the visitation area at the hottest part of the day just so that he could have 2 hours of air conditioning. And it just moved on forward from there, just hearing about the suffering in real time from everybody who's involved in this situation and realizing how detrimental it is across several areas.
Yeah, and I would say for myself that, these are the kinds of stories that we would be writing by mission anyway. But I think what I've experienced, my lived experience, is someone who lives in a low-income West Side San Antonio community, facing it every day. Where for a long time we do now have a cooling system where at least our bedroom we can cool down reliably, but we couldn't, up until a couple of years ago, where our neighbors oftentimes are living without AC, where we're finding bodies, people's in the street, And I guess what shocks me sometimes is how close together we live as a community in a city like San Antonio, but how far away our lived experience of heat can be. I go visit my my mother, and take my kids to see their grandmother, and like if we stay there for a week or 2 weeks in the summer, it's like we almost don't even experience this world. Right. And it's easy to tune out. And so that's why it's always a challenge, that we need to assert a challenge to those who are able to kind of avoid, living like the rest of the right.
If I can just piggyback on that, when you look at the prison community, they are so insulated that most people have no idea what's going on because of the negative narrative that's associated. You can be sitting next to a person who has a loved one who's incarcerated, and they're not going to tell you what's going on behind those walls. So it's really difficult, first of all, to breach those walls, to find out what's happening behind there. When I first started going to the Capitol in 2019, I can't tell you how many legislative offices didn't even know know, there was no air conditioning in the majority of the Texas prisons. At my mock cell event, I've had congressmen on the federal level come to visit, Texas congressmen, and looking at my paperwork saying they had no idea that this was taking place.
Okay. What is the best way that the average person can help change policy or show support for increased shade and cooling stations?
Oh, you're on mute.
Greg, you're on mute.
Yeah, you're not coming through, Greg.
I apologize. In terms of cooling cities, shade, and water stations, I would say find organizations who are doing that work and join them and support them. If you can't find an organization doing that work, start, if you can, get to those meetings yourself or find other people who will join you. But I can direct you, and most cities, around the state have somebody out there who's advocating. They're just looking for more people power.
Okay, all right. Any other questions from anyone? No? Okay. Well, I want to, again, I thank these panelists, just amazing testimonies. I want to let you all know that there's another panel after this one, and we hope that you'll stay for it after the break. The next panel is going to be what cities and counties can do to keep people safe. So stay tuned, and thank you for joining us for this very enlightening panel. Thank you.
Good afternoon, everyone. Thank you for staying with us for the afternoon session. This panel, panel number 4, will be on what cities and counties can do to keep us safe. I will first introduce Leslie Antunes, who is the Sustainability Administrator for the City of San Antonio's Office of Sustainability. She is a dedicated and committed public servant with 17 years of service specializing in climate initiatives, public information, crises, and media communication strategies, community engagement, and education. She is a proud alumni of New Mexico State University and UT Arlington, as well as Texas Women's Leadership Institute. We also will have the pleasure of hearing from Melanie Rubio, who is currently the Climate and Health Epidemiologist at Maricopa County Department of Public Health, which is based in Phoenix, Arizona. In her first 2 years at the health department, she has played a significant role in the department's heat response by conducting day-to-day surveillance activities and reporting trends for the department's leadership and external partners. She has also expanded the department's knowledge on the impact of heat and health by analyzing which occupations may be the most at risk during severe heat days. Then to round us out, we have David Mandula, whose research focuses on the social and health effects of natural and technical hazards with an emphasis on extreme heat and power failures. And he has worked closely with local, regional, as well as state authorities on the development and implementation of plans and programs to make communities safer and more resilient to extreme heat events. He serves at Arizona State University. He serves on leadership teams for the Urban Climate Research Center and Central Arizona Phoenix Long-Term Ecological Research Program. So we welcome our panel for this afternoon, and we'll first hear from Leslie.
Good afternoon. Thank you, Dr. Cantu, for that. It's a pleasure to be here, and I've been able to tune into some of the sessions during the day, and it's been some great discussion and information. So
I guess we can start here. The city of San Antonio really kind of began its pathway into mitigating heat in the urban heat island here in San Antonio, probably around 2021. So just about, the beginning of the pandemic and around that crazy time in the world, we started looking at what tools or what services were available as a city that we could provide for our residents. So we first kind of came about or encountered this technology that public works teams have been using across the nation, which is a cool pavement. And you can see a picture of what that installation looks like here locally. So that's kind of where we got started. Can I get next slide, please? In 2021, we did a pilot site, a very, very small, maybe a couple 100 feet, just to see again what the product was, what it could do, and if it was something we wanted to explore. Of course, we went into the pandemic and all of that kind of took a back seat. And then we fast forward to 2023 when we had the hottest summer, one of the hottest summers on record for the state of Texas and San Antonio. And so it really kind of reprioritize and kind of put heat right back on the map. And so we entered into some partnerships and some collaborations with researchers with the University of Texas at San Antonio. We really wanted to understand and we really wanted to assess urban heat and vulnerability in San Antonio. What did that look like for our communities? So as a result of our 2023 studies, we have a heat vulnerability assessment. So we essentially have the heat score for every neighborhood in San Antonio, and that looks at, transportation, access to transportation, income, race, and a number of things that we thought were important as we were looking at the compositions of these neighborhoods. They're also classified by census tract. And so that's how we narrow down what is our 4 target cool neighborhoods. So there's a couple on the west side of San Antonio, one on the east, and then one in the south. But really, this methodology is kind of what has been the foundation of our implementation work to date. Next slide, please. So part of our toolkit for our Cool Neighborhoods program. So Cool Neighborhoods is, again, that assessment that I talked about earlier, where we were looking at what's in the city's toolkit so that we can help provide some heat relief to our residents. So one of the tools that we have is Cool Roofs. This program is managed by our Neighborhood and Housing Department, and it was established in 2016. And so they've since then have done over 2,000 roofs citywide. What we have learned is that cool roofs maintain the integrity of the house. It improves the energy efficiency and reduces the utility bills of that home. And what makes a cool roof is the energy efficiency materials that are used at installation. So you have what I like to call what looks, it's a commercial grade and it's more complex than how I'm going to describe it, but it's really just like an aluminum sheet, an aluminum foil, right? You pull the foil out and you cover your food with that. So that's what this does. This is the radiant barrier that goes on the roof underlay. And then you have your white Shasta shingle that looks like your other traditional shingles. And so those two materials combined allow for the solar reflectivity of that roof to not retain that heat and return heat up that home and increase costs. So these materials, when integrated, we have seen reductions in average attic temperatures of 10 degrees. And also about a 7.3 reduction in the average electricity use in the homes. So a really good tool in our tool belt, something that I like to kind of educate and talk to about as we have these conversations or we talk to people. This material is available in the market, which means that if you are interested or it's time for your roof to get updated, you can ask your roofer for this and they can absolutely provide that
product and service for you. And so it's not something that's exclusive or specific to the city. It is available on the market. There are many manufacturers that have products to help with this type of cooling for your home. Next slide, please. Our other tool, which I talked a little bit about in our opening slide, is Cool Pavement. So our first installation, like I said, started with a very small couple 100 feet installation. Today, we are at about 35 miles paved in the city. So that's a great growth for us. I like to highlight that the city of San Antonio is among the top 3 cities in the nation that has a collective, program or system in place to mitigate heat for its residents. LA, Phoenix being those other 2 counterparts. So we collectively, get together every once in a while and idea share and learn from lessons learned. And so we are a little earlier in our deployment, but we're not too far behind from LA and Phoenix. And so the purpose of this program, again, if you haven't seen it or haven't heard of it, it's an acrylic overlay that supports the current asphalt that you see on your roadways. What this does is that it has both pavement preservation properties and also environmental benefits. We use this material, again, it's an acrylic-based material. It's a slightly lighter color and also its chemical compositions. Once it's fully installed and cured, allows for the sun to be reflected off of that surface, meaning that it's not absorbing that heat that keeps heating our neighborhoods way past, sundown. So that's been a really nice tool that we've been able to use and implement. So again, we've been using research and having that data to support our programs and initiatives. So we've seen that our surface temperature reductions for neighborhoods or roadways where we have this product installed is a difference of 6 to 12 degrees versus your traditional asphalt. So that's a considerable decrease in surface temperature, which also then translates to changes in the surface temperature and the ambient temperature of that neighborhood. So a lot of great work that's happening here in San Antonio in that space. Next slide, please. Trees is another one of our very great and awesome toolkits. Not only do they provide, some health benefits in, de-stressing people and helping people feel good about being connected to the earth, but they also provide some very, very intensive and very important cooling work for our community. So we've learned, again, under a tree canopy that it could be anywhere from 10 to 12 degrees cooler. And so we have been working with our Parks Department to increase residential tree plantings and our right-of-way plantings to ensure that we are helping these neighborhoods, use their nature-based solutions as, kind of another tool in the tool belt to make sure we are fighting the heat here locally. So we do that through, again, residential tree plantings. We've got tree adoption events. We look at, partnerships or collaborations where we could put new trees in public areas. There's an extensive education program and outreach system that we've created. And then, of course, we're constantly evaluating capital projects like bonds, right-of-ways, and then really using the community to help us spread the word and get these trees planted. One thing that we have learned in this process is that some of our neighbors are a little apprehensive about trees. Trees can be expensive to maintain, or maybe that's the perception, right? Or maybe, watering the tree is a concern when you're talking about utility and expenses and budgets in our homes. So that's something that we've been looking at and working with our community partners and trying to find solutions to still get something planted that maybe is low maintenance or maybe does not require as much care and attention, but will still give us some of those good benefits from the tree. So a work in progress, but another great tool to have in any city's toolkit. So a little bit about our plan and processes there. Next slide, please. Shade structures is another toolkit. So our Parks and Recreation Department, again, they also oversee this one, and so they have an active plan to shade playgrounds, either with these sails or with more permanent structures, depending on the design or what's available fiscally. But we have been working on that collectively. So we've been making some progress. There's about 12 to 11 parks that are scheduled every year. So we continue to build on that locally. We also have entered into a partnership with our local transit system, and we will be investing about $1 million in implementing and installing some bus shelters in some of those areas of need and high traffic where there isn't currently a bus shelter. Again, trying to improve that quality of life and a little bit of that heat relief that these residents desperately need. Next slide. So this is just a recap of our, again, Cool Neighborhoods program and those toolkits. What's in our San Antonio toolkit, our Cool Pavement, our Cool Roof project, our trees, and then our bus shelter project. So I'm going to fast forward through this one because I got my time check from Dr. Cantu, so we can go to the next slide. And lastly, our program is very founded and has a lot of, engagement and community contacts that we make. And so our target neighborhoods are about 15,000 residents. We provide this information citywide, but we really kind of do a more hyper-focused engagement boost and reach to these 15,000 residents through program mailers, door hangers, brochures, flyers. We're out at community meetings, we're hosting presentations, resource fairs, and then those community partners that are really, really important to this project. So that's a little bit of how we connect and keep our community engaged and part of this planning process. Because one of the things that's really big for us is that we don't plan for our residents, we plan with them. And so they've been a very big part of this process this whole time. Next slide. That's going to do it for me. I think I got in right on time. I look forward to hearing from the rest of the panelists. Thank you guys for allowing us this opportunity, and I'm looking forward to any questions or anything else that I can answer from the city of San Antonio. Thanks.
Thank you, Leslie. I do want to say that the community is one of the highest priorities for the Office of Sustainability, and you do it all in your actions. Thank you for that. Okay, we are going to go to Melanie Rubio at this time. Melanie, you have the floor.
Thank you so much. Can everyone hear me okay?
Yes.
Perfect. All right. Okay, I will go ahead and get started. Next slide, please. All right. Good afternoon, everyone. My name is Melanie Rubio, and I'm a climate and health epidemiologist at Maricopa County Department of Public Health. And today I am very excited to be here and sharing with you all a little bit about what Maricopa County's heat surveillance program entails. Next slide, please. All right, so we're going to cover a couple of things, kind of just give a general background as to a little bit about the landscape here in Maricopa County, a little bit more about what our heat surveillance program entails and what that process looks like. And then we'll kind of wrap it up with notable trends that we consistently see here in Maricopa County. Next slide, please. All right. So Maricopa County, for those of you who may not be aware, is in Arizona. We are the largest county in the state and the most populous, with about 4.5 million residents. And it's the fourth largest county by population in the US total. We cover a lot of area in both rural and urban communities, and we have a very prominent desert landscape, which attributes to some very extreme summer temperatures. So consistently in the summers, we do experience days where the daily high is above 110 degrees Fahrenheit, as well as little relief overnight, where daily low temperatures overnight still exceed 90 degrees Fahrenheit. So in 2024, we did see the record year with 70 days where daily high temperatures were above 110 degrees. And then consistently 2023 through 2025 ranks in the top 4 years with the highest number of days where that daily low exceeded 90 degrees. Next slide, please. So kind of to give some background as to how we came about our heat surveillance system. Next slide, please. This all kind of really started to take place in 2005. So about 20 years is the data we have to build on. So in 2006, we started conducting surveillance based on an event in 2005 where there was a heat wave where temperatures reached 116 degrees Fahrenheit, and we saw 45 heat-related deaths, 35 of which occurred over a 9-day period, and kind of really started this process and need for heat surveillance. In 2007, we started producing a public-facing annual and weekly PDF report with just some mortality data for the community. A couple years later, in 2012, we actually began incorporating some data based on the air conditioning and energy use of the decedents. So we pulled this information from preliminary investigative reports that the Office of the Medical Examiner compiles for each decedent, and we were able to begin extracting data from those and reporting back to the community. In 2017, the surveillance system began to incorporate syndromic surveillance, so looking at heat-related illness among hospital visits across the county. A couple years later, in 2022, the county kind of decided to undergo a modernization effort to kind of streamline some of the processes we had related to heat mortality surveillance. So standardizing some data, as well as trying to lean away from manual data entry and automate a couple of things. In 2024, we were very successful in launching a weekly heat dashboard that replaced the static PDF reports that we had consistently been doing weekly since 2007 for each summer. So that was very big for our department, and we still utilize it today. And currently now we are still evaluating other data variables available to us from the Office of the Medical Examiner. So we're currently in an evaluation process within our surveillance system. Next slide, please. So the main data sources we use for our heat surveillance is kind of broken up when we look at heat mortality versus heat morbidity. So our heat mortality data sources rely heavily from the Office of the Medical Examiner and their Office of Vital Records. So the Division of Epidemiology and Informatics with Maricopa County have a very close relationship with the Office of the Medical Examiner. So we receive data directly from them. And then our heat morbidity data, we actually get from the National Syndromic Surveillance Program, Essence. So we look at heat-related illnesses seen at healthcare facilities across the valley that share their data with NSSP. Next slide, please. So we're going to kind of go more in depth about what our heat surveillance process looks like. Next slide, please. So we kind of begin our case identification from the medical examiner. So the Office of the Medical Examiner actually identifies the cases that are potentially heat related based on criteria of the circumstances of death that match with their definition of a possible heat related mortality. We also gather cases potentially heat related from vital records where they're filtered by keywords and ICD-10 codes, and they're either classified as heat cause, heat contributed, or under investigation, or potentially ruled out. They're all compiled into this heat mortality database that we continue to build on throughout. And a big thing to note is that certificate data may be amended at any time during our process. So we rely heavily on the investigation that's done by the Office of the Medical Examiner. So we wait for any sort of feedback that they receive from the case as well. Next slide, please. We have two big classifications when it comes to heat-related deaths in Maricopa County. So we have heat-caused deaths, which environmental heat was directly involved in the sequence of conditions causing the death. And then heat contributed is very similar. However, environmental heat was contributed to the death, but not in the direct sequence of conditions causing the death. For the sake of this presentation, we kind of use the term heat related, and this kind of sums up both heat caused and heat contributed related deaths. And we just kind of put them under the umbrella of heat related. Next slide, please. The next major step is standardizing some of the circumstantial data we receive from the decedents of possible heat-related deaths. So once a case is confirmed by the Office of the Medical Examiner, we request a preliminary investigative report from their office, and we get more information regarding the circumstances of death. So some of those variables that we're looking at from the preliminary investigative reports is the living situation of the decedent at the time of death, place of injury and death, if this was a death that occurred inside a home, whether or not there was air conditioning present, as well as substance use and other variables. Next slide, please. So the heat mortality database that we've been building on since we've been receiving data from the Office of the Medical Examiner is compiled with the circumstantial information that we pull from the decedents. And that kind of makes up this database. With that, we also pair it with our syndromic surveillance data, and it's all displayed in our heat-related deaths dashboard next slide we'll take a look at. So this is our weekly heat-related deaths dashboard for Maricopa County. It lives on our heat webpage, and it kind of just has all of the data I've been talking about, and we update it weekly during our heat season, which is May through September each year. And during the off season, we do monthly updates on this as well. So we have our time series graphs that looks at the total number of heat-related deaths by those classifications, with heat-related deaths on the primary y-axis and environmental temperatures on the secondary. And then there's multiple tabs kind of breaking down the data by the demographics of the decedents, location, air conditioning status, as well as the syndromic aspect of our surveillance. Next slide, please. So within the Division of Epidemiology and Informatics here at Maricopa County, we provide this data to our external partners who do more of the planning and execution of heat relief plans at the county or city level. So I'm going to go over some of the valuable metrics that we share with them that kind of lead some of those efforts. And it's going to be based off 2025 data, which is still considered preliminary at this time, but we'll go into more detail. Next slide, please. So when we look historically at heat-related deaths by year in Maricopa County, we see that there was consistently an increase each year. And it's a notable saying, I feel like across the country, is that each year feels a little warmer, so this kind of makes sense. Notably, we did see our first decrease in 2024 from the prior year, and we're projected for 2025 to also experience a decrease, about 30% from 2024. So at this time, there are 430 confirmed heat-related deaths in Maricopa County that are heat-related. Next slide, please. When we break it down by the different classifications of those heat-related deaths, we do see consistently that a little bit more than half of the case deaths tend to be heat caused compared to heat contributed, and that's been consistent for at least the last 10 years. Next slide, please. We also look at the living situation of decedents at the time of death. So we compare individuals who, people who have been experiencing homelessness at the time of death to those who may not, as well as unknown, so that it's possible we don't know their living situation at the time of death. We do see that it's almost a split proportion, about 30 to 50%, sorry, each year, where the heat-related deaths are among people who are experiencing homelessness. And it is notable to see that while we do see a decrease in the total number of heat-related deaths, the proportion of people experiencing homelessness has remained pretty consistent. Next slide, please. We also explore place of injury when it comes to heat-related deaths. So place of injury relates to where a decedent may have been found already deceased or where they might have been found before being transported to a healthcare facility for medical attention and may have ultimately passed away. So we do see consistently that most of the heat-related deaths in Maricopa County occur outdoors. And outdoor can be urban areas such as bus stops or sidewalks, desert areas, or inside cars. Indoor encompasses more like homes, as just houses, apartments, mobile homes, and RVs. Next slide, please. And here we can kind of see a breakdown more of the specific demographics for the 2025 heat-related deaths. We do see that a little bit more than half of the heat-related deaths are among white non-Hispanic residents. When we look at the breakdown by sex, we see that almost 3/4 of the heat-related deaths are among male, and that's a consistent demographic we see year to year. And when we break it down by the age groups, we do see that older populations make up more than half of the heat-related deaths. And once again, that is also really consistent year to year here in Maricopa County. Next slide, please. We also take a look at heat-related deaths that substance use may have been among those as well. So for us, we classify as substance-involved death, heat death that is where the cause of death field on the death certificate also had an ICD-10 code pertaining to a drug overdose. So we do see that a little bit more than half of the heat-related deaths are substance use related in some way. In our annual report, we do a little bit more of a breakdown as to some of those specific substances and such. Next slide, please. And at this time, that is all I have. I know it covered a lot of information, but we have all of our annual reports available online, as well as a methodology white paper that goes into detail about the data extraction and that case identification. And then we also have a data request portal that's countywide. But yeah, thank you so much for your time, and I will hand it back to Dr. Cantu.
I'm on mute, sorry. Thank you so much, Melanie. Very informative. Also good to hear what's going on in another state. Now we'll hear from David.
Yeah, thank you, Dr. Cantu. Real honor to be in everyone's company today, and thanks for giving us a chance to share a little bit more from Arizona. Of course, very close partners with the county health department here, and today I'll be presenting on some of the work happening at the city of Phoenix. And yeah, I wanted to talk a little bit about our approach seasonally here. I think before I started this role with the city in our heat office, I would have expected that there would be a lot of city programs that turn on and off depending on if the Weather Service is issuing an extreme heat warning. And the Weather Service are dear partners and friends of ours. So please don't take any of this to be any slight on the Weather Service. But as is the case here and certainly across much of the Sun Belt, dangerous heat persists outside of those extreme heat warning days. So the vast majority of our programs in the city of Phoenix operate for our whole heat season, May 1st through September 30th, as modified by the weather. So that's why you see the title here. And I also, we do talk about heat and health as an emergency, but as a lowercase e emergency. As many of you know, there's this ongoing national dialogue about how we are formally going to talk about heat and respond to heat. And right now we are still in the lowercase e emergency, and that we don't have a lot happening, certainly in Phoenix and even in Arizona more broadly, for formal declarations. The governor issued one declaration a couple of years ago. But against that background, as we move on to the next slide, I'll be sharing just some brief highlights of what our plan is in the summer at the city and how it's implemented. It's a plan that's implemented with a wide range of community partners. Some of you can see on the slide here, and we're so appreciative of the collaborative effort. We definitely appreciate that the city's reach can only be so far. And something that has really resonated with me in 4 years here, as we go to the next slide, is how intersectional heat is with the work of the city and so many departments. I think it's actually quite a challenging exercise to find a city department that is not involved in heat work or is not impacted by heat in some way. And that's great because it means we have a lot of resources to marshal toward this challenge. But it's also hard because it means there's a lot of coordination required across the whole heat portfolio. And that's a sweet spot, I think, that creating a heat office here in Phoenix has been able to fill, is having folks whose job is to look at the big picture across all departments. As we move on, yeah, just want to highlight and resonate some comments that we've heard earlier. Really important time for the national conversation on heat. This is a photo of our mayor, Kate Gallego, and Senator Ruben Gallego of Arizona when they were announcing a proposal a couple of years ago to add extreme heat to the Stafford Act that would arguably make it clearer that extreme heat fits into the mandate of FEMA. This is a complex discussion that's playing out, but I include this slide just as a sign of the times that a lot is changing at all levels of government and across all organizations on how we approach to heat, and that couldn't be happening too soon. Next slide. That's complemented by agency work at the federal level down to local government. Here are some of the documents that have come out in just the past couple of years from the White House: National Heat Strategy, National Climate Resilience Framework. And if we move on one more slide, I want to acknowledge that all of this innovation and this inflection point that we're at for heat work is happening into an environment in which, at least here in Arizona, we know a lot about the nature of the problem. And Melanie did a great job describing this in the previous slide. I think it is certainly fair to say we could always know more, right? I don't know the 100 addresses that are going to have a heat-related death from indoor circumstances this year because their air conditioner went down unexpectedly. I don't know that right now. But as we are crafting our city programs, we do have good general information about the groups that are most impacted. And for us here in Phoenix, as Melanie alluded to, people experiencing homelessness and substance users show up very disproportionately in our heat-related death records. So if we're not thinking about those populations first and foremost as we're implementing our summer heat response plan, we're limiting our ability to move the needle. Next slide, please. Just very briefly, the origin story of the heat office, and it's certainly not my perspective that creating a specifically named heat office in local government is the right strategy everywhere. And I think Leslie is a great counterexample to that. There's wonderful heat work and heat leadership happening in San Antonio, even though it doesn't have exactly the same look and feel as we do here in Phoenix. So heat leadership can exist in all shapes, sizes, forms and colors. Doesn't have to be within the name and model that we have. But I think what Leslie's case and our case are also instructive too, that knowing where to take the heat conversation is really important. And that is against this vacuum and void that has emerged in the public conversation in the academic literature over the past few years, I think well captured by my colleague Melissa Guardaro in an article a couple of years ago. Everybody cares about heat, but nobody interprets it as their job. That was the sentiment even just as a few years ago. Let's move on one more slide, please. Here's an academic version of that when our colleagues look formally at local government plans. Heat might show up, but the sections of these plans related to heat, probably with San Antonio as an exception, and certainly Phoenix, the heat sections are really thin if they're present at all. And for what we're gathered here today because of the importance of the issue, and if our formal plans aren't doing a good job thinking about heat, surely we're leaving some opportunities on the table. Next slide, please. This is the local version of that quote. We had at a meeting not so dissimilar to this one in person. I think this would have been 5 or 6 years ago now here in Arizona. Emergency managers in the room stood up and said, "We're not sure it's our job to be here." And that was a flashing red light to us that this governance gap that was being theoretically discussed in the literature was real and really like right in front of our eyes. And I suspect a vast cross-section of the public and knowledgeable people would expect emergency managers would be involved in the heat work. And if we were seeing emergency managers say, whoa, we're not so sure about this, also suggesting that opportunities are being left on the table. Next slide, please. So now 4.5 years ago, our mayor, Kate Gallego, who's a real leader on climate and sustainability, proposed creating an office as part of the local government structure focused on heat. And I have most days, I think it's a privilege to lead that office. It is, it's challenging work because of the intersectionality of heat that we've heard about so much today. The heat office itself has now grown to 10. And we are part of the city manager office here, which implies that we're supposed to be coordinating with and working through all the city departments. And happy to talk about the minutia of implementing a heat office in the local government structure with anyone anytime. I know that might not be everybody's cup of tea, but I feel like we've learned a lot on that topic. Let's move on to talk more about the program. So one of the first actions that the heat office took when we started in late 2021, the city did not have a heat plan, did not have a summer plan. There was certainly work happening. So we went around and asked all the departments what they were doing, and we packaged it together into a somewhat glorified list that we called the city's first heat response plan. And that plan has grown and evolved now into its fourth or fifth iteration, unanimously adopted by our city council each year. And it details the roughly 24 strategies we have in place as a city to address these 6 thematic areas. This is how the plan is organized. You can see what they are on the slides. And here, like in your jurisdictions as well, in some of these categories, the city can do more. In others, there might be other players who are the leaders, but this is how we're getting our thoughts organized. And as we move to the next slide, just a couple of examples of some of the specific actions addressing those priorities. The city is certainly a very active participant in our regional network of cooling centers, hydration stations, et cetera. It could be argued that Phoenix is the #1 host in terms of number of sites, but we really are focused on that. But we also know that our sites don't serve everyone. There are all sorts of reasons. Folks might not be well served by municipal government buildings providing heat relief. So we've been investing in our partners as well. The church that's across the corner from the library, that's also a cooling center. We want them to be as successful as possible as well. They can likely serve different and more people than we're serving at our sites. We've been giving grants out on supplies to those organizations. I know a bit of a sore subject in front of a Texas audience, but we do have some formal ordinances in place, both a worker safety ordinance and a indoor cooling ordinance that protects renters. And there's a lot of action through that each year. And then here, and likely the case across parts of Texas, folks really enjoy recreating even in the summer heat. And our community emergency response team volunteers have been among the volunteer groups helping us ensure that recreation can happen safely. So it's just a sample of actions in the plan, but let me take you in our thoughts for how we try to improve the plan every year. These are some of the highlights and changes to the plan that we talked about with our city council just a few months ago. Of the roughly 200 heat relief sites that exist across Maricopa County, there are a select few that have enhanced services and longer hours, including one 24/7 site that the city of Phoenix operates. And each year we are looking at what the right locations are, what the operating schedule is, what the operating model looks like in terms of mental behavioral health providers at the facilities, the security presence, what the city staff involvement will look like as well. So we've been making changes there, and I'll talk about one important change in a few moments. We're rolling out a new training program for city employees. We're in the curriculum design stage right now. We have this dream. Eventually, the person who's collecting the trash from your home will know what a cooling center is and can help you get connected to one, right? Somehow they're at least familiar with what the programs are. And we're starting this training with our city workforce that works at our roughly 60 heat relief sites, not just to help them understand the signs and symptoms of heat illness, but also what their roles and responsibilities are in this capacity. And of course, at public facilities, we have everything from the 40-year city veteran to the person who's there for a summer job, and how do we get everybody operating off of a consistent baseline? It's an interesting challenge that we've found ourselves working on. Getting supplies out to community partners. We keep tweaking that model year in and year out. This year, we've brought on a third party who is the supply chain and warehousing manager for that work. And then we talked a little bit about the housing stock earlier, but we have increasing emphasis here in our region on residents of mobile and manufactured home communities, as well as some of our senior communities, and just trying to be boots on the ground, get the word out. Let's go on to the next slide. Here, we'll go through these really quickly. Just wanted to give a couple of examples of scale and some details, and maybe we'll have a little bit of discussion of these later. Here's a picture of the front door of our 24/7 heat relief site. That last year, between this site and a few of these other enhanced sites, saw more than 5,000 unduplicated visitors. And from these sites, more than 700 placements into programs that include housing and shelter. Air conditioning and cold water is great in the moment, but the fact that we've been able to line up so many providers and services to facilitate dialogue at these sites, I think is the real win for heat resilience. Next slide, please. Another important change that we're making. Last year, we were overwhelmed a bit by how many families were seeking heat relief at this site. We knew the need was out there, but we were surprised at how many folks we saw coming in that were family units in the community. This was the space as it looked last year. That will still exist at our site, but we have a whole new provider who's come on board who will really be focused on and dedicated to families seeking heat relief, certainly including families experiencing homelessness that are seeking heat relief. So we're really grateful to that partner who's come on board this year. Next slide, please. Yeah, just a little bit more about this training program. We're thankful to the Federal Emergency Management Agency. We have a BRIC grant to work on this, and it's been really fun talking to different city departments and external partners on what this could look like. We've learned a lot, and I've been really surprised at the validation we've heard from city employees, an appetite to hear this. We're hearing from a wide cross-section of employees that they see a lot of heat-related needs in the community. They don't necessarily always feel empowered or knowledgeable on exactly how to respond. So we appreciate hearing that. And just a couple more slides as we wrap up here. Definitely don't want to shortchange for discussion. Heat relief supply program has been very, very popular and important. I think it's facilitated some networking in the community. So here's one of our happy partners picking up some supplies, and let's go one more. Mobile home and senior outreach. This has been a great way for us to partner with the local Red Cross, the regional Red Cross, and some nursing students as well. I may just have one more slide before we wrap up. Let's see. Oh yeah, one important note here. We'll skip ahead to the end because I do want to get to Q&A, but I want to give just a final word of appreciation to our Office of Emergency Management and the other departments that participate in this work. When we first moved into operating 24/7 and extended hour sites a few years ago, emergency management came in and really took over the coordination of that work under an incident command type of structure. And it made all the difference in the world. And we can click ahead to there's a sort of wrap up slide here. I'm happy to talk about these others. Go ahead. One more. Thank you. It's made all the difference in the world, emergency management being involved. The structure, the vocabulary, the perspective, the resources, it really took our whole heat program a level up. And for me, some of the working in local government, where I think there's a perception that government moves slowly sometimes. Our experience here in Phoenix has been, at least on heat, we've evolved relatively quickly. In just a few years' time, we've gone from a position where the emergency managers were trying to stay away from this conversation to now they are owning it and leading it. And I hope I leave that as a word of encouragement for how all of our work evolves on this important topic. Thanks again for the chance to spend some time with you.
Thank you so much for all the panel members. And we're going to spend some time in questions and answers. The one thing that comes to my mind for the three of you is I've toured nursing students at Haven for Hope, which is our campus for the unsheltered. And as I go into the courtyard there, I'm always amazed at the number of older adults or seniors that are there. And so I'm wondering about a nexus between the morbidity and mortality. Melanie, I think you showed that more of those heat-related death work were in the age group of 50 to 64. And then just the unhoused of older adults. It seems like all those three things come together and contribute to this issue. And we talked earlier about the seniors being one of the most vulnerable categories. But what about seniors that are unhoused? I mean, it seems like the risk is tripled when it comes to heat and severe heat. So I just wonder if anyone has some thoughts about that.
I guess I can just start it off and say, I mean, yes, it's the head on the nail. Both of those groups are very susceptible, and the data year after year confirms that they are the most vulnerable within our communities, both unhoused older adults and, like you said, unhoused older adults. I can't speak exactly to what that number represents in total for our unhoused, of how many of those fall within that age category, but it is something that, at least from my perspective here at the county, I'm not sure what's being done boots on the ground, but I do know that we recognize that they're vulnerable. And I don't know if David has anything
Yeah,
he can
just
speak to
very
that.
briefly,
Yeah.
I definitely want to hear from Leslie on this one too. I think there's some data in our region that seniors represent the fastest growing subset of the population experiencing homelessness. Maybe that's a national pattern. I'm not sure, but we're really lucky right now. We shouldn't be relying on luck that one of our major partners for these extended hour and enhanced sites specifically focuses on seniors experiencing homelessness. So we're trying to do everything we can to lean in to their efforts. They have a beautiful model for their work that they've developed over the past few years. And yeah, I couldn't agree with you more that this is a topic we need to keep leaning into.
Yeah, I think so I just wrote a paper for school. I'm a master in public health graduate student again, in the concentration in environmental health. And that's one of the things I wrote about, was how our senior population in San Antonio is one of the quickest growing populations, but is also one of the most vulnerable because of all of the things that we know and all of the exacerbations from heat. And so one of the things that the city has done, in general for the houses population, is they actually created a whole nother department that focuses on that specific service. And so that includes our seniors that are in that category. So we are allocating and really changing how we're, operating to make sure that we are providing those services and those resources. So in San Antonio, yes, in the last year, because that change just happened last fiscal year, we have changed operations to take on a more, proactive approach to that challenge in our community. And of course, we work closely with them, Office of Emergency Management, but they're well versed in all of the things heat. And so, once that starts to, those numbers start to rise, we're on calls about water and services and resources to make sure that we're all collaborating and making sure that those neighbors get the help that they need.
It seems like it's at least you're having that same awareness at the city level for the issues around that. I would also say there's probably some mental health issues as well, because in some way, particularly if that senior is over 65, in some way they haven't been caught by the safety net before they become unhoused. So I want to get to a question that Bill Barker has in the chat. Can you say something about the Chilled Drinking Water Initiative?
Yeah, thanks for the question, Bill. I think this question is for us in Phoenix. Uh, yeah, I I don't know how many American cities have a great public water fountain program. I generally don't know, but I suspect it's not many. And I'm not ready to proclaim that Phoenix is there either. In fact, I think you can go for quite a while walking through our city and not encounter any public water fountains, and that's different than what we see elsewhere around the world. So our Office of Innovation here has been leading an effort to try to change that narrative. And they've been deploying, I think we're up to over a dozen new fountains out throughout the city that have advanced technology in a number of ways, monitoring water distribution and helping keep the surfaces cool there. 'Cause I think we've all seen that deteriorated water fountain in public space that is not appetizing whatsoever to think about consuming water from. And they've been conducting some very rigorous monitoring and evaluation of these to think about what the path looks like moving forward. So Bill, I'd have to refer you to them for some more details, but I think the short version is we're we're trying as a city to increase the accessibility of chilled drinking water out on our very hot streetscape.
Well, that very interesting that you would have that initiative. You may have some of the same issues in Arizona that we do here in San Antonio, or at least Maricopa County, is that in San Antonio, we are so spread out, right? So you've got your urban core and then you've got everything else growing out on the core, or around the core, I should say. And you're totally right. I don't know if there's any other water fountains accessible except in the downtown area, Leslie, is that correct? Yeah.
Mute myself. Yeah,
Mhm.
we've been looking at that, and David's absolutely right. Those
Yeah.
water fountains, I'm gonna say that it's the similar kind of example of like bus shelters. Everybody's looking at these like infrastructure pieces, and we're all trying to figure it out. And that
Mhm.
solution looks very different for every community because we all experience it very differently, right? The heat in Phoenix is a dry heat. The heat here is very different. So again, what could work for them may not work for us. And so I add water fountains to that. We're all trying to kind of figure out what is that solution. And so, yes, it's one of those things that we need to do better at. I will give a shout out though to our downtown ambassadors. We have a group that stands in like high traffic areas downtown. They have a little paleta cart, but instead of paletas, they're giving out water. And so it's, to tourists, it's to our city staff, it's to, construction workers, it's to anybody really just kind of commuting up and down that busy corridor. If, they need that relief, I look out for those umbrellas and I'm like, there's water like at the end of the street if for whatever reason I don't have my water jug, So, there are little things that we're trying to do to kind of mitigate and get around that. But, other than that permanent solution of installing the infrastructure, that's just something that we have currently as a temporary kind of aid, but we definitely need to look into it further.
Thank you. Thank you for that, Leslie. And Bill says here, oh, no, you're responding to Bill. Your downtown Phoenix ambassadors, you have that program as well, right? With our downtown business authority. Yes, and they are you can spot them really quickly with the umbrella, with the little cart. Yes, very nice. Good. Any other questions or comments? I am looking to see if there's anything else.
Well, Doctor, I'd just like to add appreciation and congratulations for the convening all together. Uh, we we uh, we had an interesting moment in the COVID era when the sustainability director of a neighboring city called and asked what the policy should be in COVID for ramadas in parks. This was in April as we were heading into the summer. Ramadas, of course, really important for shade, also really attractive for congregation. That was a tension that time. And that question that he asked, this Braden Kay, for those of you who know him now in the state of California, was the springboard to a lot of collaboration. We very quickly realized how many shared questions we had. So I'm very hopeful, as for your leadership and as you've kicked off this dialogue, that many benefits will come it. We've been lucky enough to get the snowball rolling a little bit here in Arizona for that cross-jurisdictional dialogue, and I think it's paid off in a big way. And just wanted to applaud and appreciate how it's happening there as well.
Collaboration certainly is the key. I mean, this is a issue that cuts across so many different cities, states, etc. And so we come together to solve these issues, developing strategies.
If you could each put into the chat really quickly which breakout room you'd like to be in, whether you'd like to talk about what clinicians can do or talk about what cities, counties, and nonprofits can do. Reach out to Dr. McCarthy. Do you have time to do a report back from the clinicians group before you need to leave? We can't hear you.
Sorry, I was trying to read. Yes, and sorry to cut you off, Melissa. I didn't know if you saw the 2-minute warning. We were still actively discussing. So yes, we just discuss about how wonderful the summit was, and it did provide just a good breadth of information from from the medical and then the community level. Dr. Dominic said, it would be great to have resources available from this group, because there was so much communication going on, where people are like, your email, can I have your email, and this paper and that paper, to use, where do we go from here? Because I asked, what was good, or what should we do in the future? And it's like, well, we have this momentum, and until Heat Summit 2, what are we going to do in the interim? And maybe you could say it better, Dominique, but how can we leverage this interested group moving forward now? Also, just being more aware from a clinician perspective of heat illness, the need for documentation, for death certificates, as well as just for heat-related illnesses. Now, just understanding that we need to have the documentation of the environmental component, and also I'm going to share the ICD-10 heat codes and how to leverage those, because there's just there's just not those have just changed, and they weren't very accessible in the ICD-9, and the ICD-10 are a little bit better, but still we just need to kind of have that more awareness and put those ICD-10 codes in, so we can hopefully move forward with resources and legislation, having those statistics available to legislators. If there is anything else, I may have skipped it if anybody else wants to jump in. Sheila or Dominique or Melissa. Sorry, Dr. Dominique, Dr. Modi?
No, I think that covers it. I think that was it.
So, Ashley, do you want to report back for the nonprofits and cities and counties group?
Yeah, sure. That sounds good. I'll try and be concise. So we talked a lot about what we're seeing as the current challenges and opportunities in heat response. So it was highlighted that some locations have maybe a climate action plan, but they lack heat specific objectives. So we talked about the Dallas Climate Action Plan, which has 8 objectives, but none of them directly address heat, because the thinking may be that heat is less well established as a health concern around climate change, whereas something like air quality has been much better established over several years with the EPA air quality framework, and then since the 1970s, there's clear language and a clear medical framework around it. Whereas heat's relatively new and has less representation in some of our governance structures. So we thought that was one challenge, even though, of course, we can't even address air quality without considering heat as it's such a synergistic relationship. We talked then a little bit around the intersection between poverty and heat, and of course, the wealth disparities creating disproportionate heat impacts. Lower income residents lacking air conditioning or having higher heat-related deaths, but also maybe not able to afford those housing repairs, roof maintenance, basic things like utility bills. So looking at more at those social determinants that compound heat vulnerability, but also perhaps make it less likely that those communities will prioritize heat improvements because they have other things to spend their money on. We talked about community engagement and cross-sector collaboration, and particularly the challenge about dehumanization of unhoused populations, which was considered to be increasing over the last 10 years. So the need to really address that root challenge while also building up a research base and a data foundation to be able to prioritize heat response. Some successful collaboration models were highlighted. So we talked about the environmental collaborative in San Antonio, which meets monthly. And then I think it was Harris County, there was a heat mapping campaign, which was also highlighted about a really strong partnership between county organizations, nonprofits, and community volunteers, which created a heat map dashboard, which was used by several organizations, but then lost funding. The one challenge, again, to be addressed is, like, especially if the federal funding has been withdrawn recently, to be looking for more diverse and sustainable ways of funding these kind of cross-organizational collaborations. The challenge was highlighted that, of course, there's often the good work going on, but in silos. So the importance of bringing together smaller organizations for university partnerships for research, for example, and really bringing lived experience of community members who are most impacted, that environmental intelligence, into the discussion, and making sure that is really highlighted and that is also built into these collaborative efforts. And so we talked a little bit about unconventional partnerships between government, academia, healthcare, politicians, and communities. And then we finished by talking about how Texas PSR could be playing a more strategic role in bringing these groups together. And we used this great event, for example, as a really good start, bringing different groups together, different voices and experiences together. And then really training clinicians in advocacy and utilizing their policymaker connections was also brought up as a next step. And using, again, that health framing and to bring diverse stakeholders together. And then, we talked a little bit about potentially having a regional approach next time. So we could have convenings in Houston, Dallas, San Antonio. Then that would help us then build a more sort of practical foundation, because we're all in the same location, and could move that forward. And I think those were the main things, but does anybody else from the group like to come in and just anything else you'd like to add or anything I missed?
That was really great, Ashley. Thank y'all for attending. I'm going to thank you for all the speakers for being just incredibly awesome and smart and inspiring. I want to thank our sponsors again, which include Dr. Adelita Cantu, the Alliance of Nurses for Healthy Environments, Concentra Occupational Health, the George and Cynthia Mitchell Foundation, the Heat and Air Quality, or HAC app, and Ascension Seton, as well as our publicity partners, which include the Association of Occupational and Environmental Clinics, the Environmental Defense Fund, Environment Texas, the Texas Public Health Coalition. I know some of you are shocked that we have one of those, the Medical Consortium on Climate and Health, and Physicians for Social Responsibility and Public Citizen.